Yes. How are you, Lucas?
I'm fine. I'm so far so good. Everything is okay.
Yeah.
Life is going on. We are working very hard in every manner, preparing Belgrade for next year to welcoming you for the ENS Congress and a lot of activities.
Nice. And we'll reciprocate by holding, I think, finally the Cannes Congress as well.
Yeah.
We're hoping sometime in end of June or July, because August might be a problem because of our elections. So
usually for ENS Congress on the very first day before the opening ceremony, we have a joint venture with continental societies. ENS a joint venture with each continental society. Nice. High-level scientific program session. So you will receive also information for this and invitation to participate.
We look forward to it. We really want to get out of this pandemic and start meeting again.
No. Until October next year, the Congress will be purely physical, no hybrid. So we will survive and we will beat the corona, and everything will be like usual. I mean, we have to face the fact that we have to get used to this situation and to live with this.
We have to live with it. We are trying to, but good. And Chandra, you keeping well?
Hi, good. Thanks, Moody.
Yeah. What time is it there? You already look tired. Have you been operating?
I just got out of OR. It's been a little busy day.
Yeah.
And not finished yet. Need to see a few people before I actually join you, but I'll be on the side. Muted probably. Nice program yesterday, Imad.
Thank you. I hope you enjoyed the discussion. It was a nice discussion at the end regarding the hybrid neurosurgeon, vascular neurosurgeon. Is it better to be two separate service or really get the neurosurgeon to be doing that part? I myself, I concurred with Bill's opinion that the training should start from day one to have both interventional technique and the microsurgical technique from the beginning, rather than to wait for a fellowship to integrate the young generation in that. But others have different opinion, which is understandable. Yeah, there is a lot of politics entailed, because you see, this is a protective discipline that intervention radiologists, they will say, okay, neurosurgeons, they are not trained in physics of radiology. Hello? Hello?
Hello, we can hear you, Imad.
You can hear me? Yeah. Yeah, because I saw that in some of the shot them phone. And for neurosurgeon, we feel clinical knowledge and evaluation should be essential to manage these cases at best and to handle complication. So we'll see how it progresses over the next few years.
Hello, Najia.
Najia with us now. Hi. Unmute yourself if you want to talk, Najia. I see you have joined us, perhaps not with audio yet.
Hello, how are you? Good morning here in
Mexico. Good to see you, Victor. How are you?
Hi, Victor. How are you?
So what is the time now, Victor, at your place?
Excuse me?
Victor, what is the time now at your place?
6 o'clock.
Oh my! Yeah. Yeah, this is the problem. We could not fit the best time for everyone.
How are you, Vladimir?
Hi.
Hi, Vladimir. Good to see
Hi.
you.
Kazadi, Imad, Victor,
Hi.
hello. Good to see you again.
Hello, Vlad. Hello, Vlad. Very nice
Oh.
to see you.
It was a good one yesterday, Imad.
It was a wonderful discussion at the end with
Yeah, that was-
I was just telling them hybrid or mono.
Yeah.
But
Philosophy about
we all agree neurosurgeons should control it in one way or other.
Exactly. We are the leaders, not
Yeah,
the endovascular people, not the gamma knife people.
Hmm.
We
Hello,
are the
Mahmoud.
clinicians.
Mahmoud Qureshi. Hello, how are you? Professor Nadia Alabadi. Very nice to see you here. Dr. Rasulik.
Yeah, hello.
Hello.
Hi, everyone.
Hi, Nadia.
How are you?
Now we can hear you.
How are
and
you,
see
Ahmed?
live. I'm fine. Good to have you.
Hi, Naja. How are you?
It's my pleasure
Ramesh.
and honor to be with
Ramesh.
you.
Hi, Victor. Hi.
Ramesh, hello.
Daddy, Lucas, Victor.
Hi, Nadia. Hi.
Hi, hi. How are you? So I think it will start in how many times? Because I have just to see 3 patients before.
You have 2 minutes for each patient.
20 minutes.
No, we will be starting in
Back,
about 5 minutes time. In 5 minutes, we will start. And
Okay.
15 minutes each one of you will have a presentation inclusive. If we are left with good time like yesterday, we initiate trigger some discussion.
Okay. Good. So I'm coming back in 5 minutes. Amen.
All right.
Okay.
Good to see you. Okay, waiting for you later.
Hi, Ramesh. How are you?
Yeah, Moody.
Keeping well, keeping sane.
Yeah,
That's-
could say that.
Okay.
So excited to see everyone. Hopefully next year soon, all of us together.
Yeah, I'm really looking forward to Bogota for some reason, but just anywhere.
Vladimir, because yesterday somebody sent me an email questioning whether I'm coming to Bogota or not. I said, yes. Basically, from my side, yes. He was worried because, you see, I think the cases in Germany, they are increasing, in Europe in general.
Europe, I think.
We have
it's,
an outbreak now. We have the highest number since the beginning of the pandemic just now. But it must decrease again.
Yeah, but I hope now we all have the 3 vaccination shots in our body.
Sure we do.
Should we go to the Saturn or to the moon? I have no problem.
By Bogota time, we shall have 4. You shall have the 4th.
but I
And
think
some of us will also get infected, so that will also give us more immunity.
More immunity. And there is medical treatment now for the corona.
Exactly.
Yes.
Exactly. Getting better.
But I think
making the business of our cost.
having a triple vaccinated really helps, because a couple of weeks ago, I went to India. A lot of cases in India, especially where I am from, Kerala, but I was okay. And there people were getting COVID everywhere, but I didn't get it. Maybe because of the vaccination, I'm not sure. But
yeah, because you are young and beautiful. That's what it is. We cannot afford it.
yeah.
Oh.
No, it's only danger that they will have it in that time in Bogota, and there will be quarantine. And I wouldn't go there to spend a week in a hotel locked down. You know, that would be stress. Yeah. Let's hope it will not happen.
Yeah.
Hi, Andre.
Is it real, the quarantine? Hi, Ramesh.
Hi, Kasadi.
How are you?
Good to see you all.
You're eating healthy.
Andre, hello.
Hi, Andre. How are you?
Imad, good to see you.
To
Lucas,
see you.
same.
Hi, Andre.
Moody, Victor is again here. Kasadi also. Ramesh.
How are you?
Very
Hi,
nice.
Andre.
Good.
The usual
Yes, absolutely.
Andre.
Especially.
Andre, hope you could come to Mexico next year. We are going to organize 2 congresses. The first one on May in Acapulco, and the other one in Villahermosa, Tabasco on November. These are very nice places. Vlad has been here several times in the southeast, so it's a very, very nice place.
Great country.
Yeah,
Great
I know,
nature.
but that
And
is
nice
because
people.
of his hobby, the entomology. So he
Exactly.
loves to be in that
Exactly.
area
No.
to look for another one. Already one of these species is named after him. So
That's true.
yeah.
That's true. Andre, Mexico has a specific feature because the population is still the same, you know. They only changed the ruler. But down south, it's still Mayas and all these that people never moved. So
Yes,
it's a very settled country, unlike
Yes,
many others.
it is indeed. It is indeed. Yes.
Yeah.
Atul, good to see you.
Atul, good.
Atul?
Atul.
How are you? Everything okay?
Yeah, good.
That's good.
Sure.
Thank you. Thanks for joining us.
Thank
I
you.
think we have 2 minutes, so I will make use of that one to introduce the 2 colleague moderators, Victor Hugo from Mexico, and he just gave you the invitation to Acapulco. All of you should come and should dive from the cliff down to there. And
Oh, that now
It's
probably
for Ramesh only.
I will watch it. I will watch it.
We'll
Not
watch it,
jump
yeah.
at all.
We'll
No,
do
no, no
a
way.
pre-dive,
No
a
way.
pre-dive. And Dr. Professor Kasadi from Zimbabwe, wonderful place. We're looking forward to have this repeated visit to your place, Kasadi. Hopefully next year as well.
That would be great.
Will do something for us.
Absolutely.
Yeah.
Absolutely. Yes.
We will try to continue the spirit of doing not only the webinars, but on-site courses and cadaver dissection. This is what most of the young trainees missing as we discuss. So without further ado, I think we can start that session. There will be 2 sessions, one on peripheral nerves and spine, including spine tumor. We added Professor Najia because she could not make it for Thursday. We advanced her. So we try to make the brainstem part of the spinal cord a little bit higher. So she will conclude the first session, and the second session will be on pituitary and endoscopy. Please, Professor Hugo, Victor, and Kasadi, go ahead with the moderation.
Okay.
Kasadi,
You like to start?
okay, thank you so much. I feel very honored to be with all of you. So now we are going to start this fantastic webinar that includes 46 brain surgeons around the world. This is amazing webinar. So we are going to start with Dr. Lucas Rasulik with the lecture about Think Global, Act Local, the centrality of neurosurgery in spinal nerves. Thank you, Dr. Lucas Rasulik. Go ahead, please. It's okay?
Yes, it is okay. Good afternoon, everybody. Greetings from Valencia. I mean, greetings from Serbia. Actually, via Valencia. Here I am participating in ENS training course, spine course, generally presenting this presentation like 4 months ago when excellent webinar was organized honoring Professor Majid Samit. This outstanding webinar honoring Professor Franco Servadei gives me a great pleasure and honor to present my presentation, Think Global, Act Local, the centrality of peripheral neurosurgery, which was closely connected and related to all activities with Professor Franco Servadei contribute in favor of developing of peripheral neurosurgery worldwide. I don't have anything to disclose, and this is something which refresh my memories from our more than I don't know how many meetings all over the world and mutual activities with Professor Franco Servadei all over the world, and nice memories what we share together, and reminding us what we did together. This is a famous slide of Professor Franco Servadei, Global Neurosurgical Workforce, a mixed methods assessment of density of growth, 49,000 neurosurgeons all over the world, missing more than 23,000 neurosurgeons in developing countries. Regarding peripheral neurosurgery and neurosurgeons, this is a survey made by WFNS that only 48.7% of respondents believe that they had been given sufficient exposure to peripheral neurosurgery during residency training. The overwhelming majority, 97% of respondents, favored keeping peripheral neurosurgery as a part of neurosurgical curriculum. This is something which reflects our activities, increasing number of publications in leading journals of neurosurgery, peripheral nerve publications in major journals in 2020 and 2021. As you can see, the number of papers related to peripheral neurosurgery is quite big. Learning pyramid in peripheral neurosurgery is very important, and this is something which we are working now on, thanks to huge efforts of Professor Franco Servadei and all of us in making this possible for now speaking about peripheral neurosurgery to every part of the world. Geographically, when we are speaking about peripheral neurosurgery in UK, France, China, Korea, Japan, usually orthopedic surgeons and plastic surgeons are mainly performing peripheral neurosurgery. But in the United States, Germany, Spain, Italy, and other parts of the world, Europe, neurosurgeons are performing this. True meaning of peripheral neurosurgery is interdisciplinary, taking care about geographical specificities, favorizing meticulous exam preoperatively by surgeon, and meticulous follow-up of the patient with peripheral neurosurgery diseases treated surgically by the surgeon. He had lesions of related to the peripheral nervous system, which is an essential part of nervous system, and are heterogeneous. Studying individual cases have more values, and cohort studies are not reflective of real world, very well-known Heisenberg effect. So true internationalism in peripheral neurosurgery is very important. Tolerance towards diversity, ability to look things differently, accumulating experience by applying well thought over strategies, and exposure, surgically treating the patients with peripheral neurosurgery disease. This is my favorite slide. How world would like in future. Friend of mine, Karl-Heinz Lein, wrote this book, Earth 5.0, Provoking the Future. And might be that we seeking the perfection we'll have the face. We are now actually facing with this fact that machine is doing things exactly the same like a man. This is something which in peripheral neurosurgery is really specific issue, and it's hardly can be introduced in all parts of the world, which is our goal, to favorize the surgery of the peripheral neurosurgery in a whole part of the world. So classic format of education, frontal lessons with some hands-on, cadaver lab simulation, web access organized by ad hoc committees are very well known. This is a famous slide that when we do only PowerPoint, this is not very useful. Interactive communication, which is very important through faculty participant discussion group breakout session hands-on is of outstanding importance. There are huge activities of WFNS Foundation, which was already established by our giants of neurosurgery, Professor Sami, Professor Basso, now leading by Professor Araez and Professor Misra. Generally speaking, Professor Franco Servadei gave a great effort in terms of developing all this and putting in a practice in a whole world, favorizing low and middle income countries. This is a very well-known WFNS Foundation Training Centers program, which can be used for these purposes in terms of making available peripheral neurosurgery to the all part of the world, especially in low and low middle income countries. These are full program training centers already established in Africa, and this can be also used in collaboration with national and continental societies. Also, this is some good results and pioneer efforts in brain surgery worldwide under the Franco Servadei leadership. So communication is very important. We have to inform the neurosurgical community, inform about neurosurgery. And this is still a problem that we have still in numerous countries around the globe, a low number of neurosurgeons, not only in Africa. And the WFNS Peripheral Neurosurgery Committee initiated a task force group focusing on the education in peripheral neurosurgery in low middle income countries. I will tell you a few words about that later. Current standing in peripheral neurosurgery is a KISS strategy, keep it simple surgeon. So this is a neurolysis, neurografting, neurotransfer standard technique, which is direct suturing, which is very important to provide to our patients to obtain the functioning of the nerve. This is interfascicular nerve grafting and cable nerve grafting. This is something which is standard techniques. So we prepare surgical curriculum outlining surgical procedure from basic to innovative. We are creating instructional videos that will follow the surgical curriculum, taking care about KISS, keep it simple certain strategies. We are making a collection of video presentation lectures within the WFNS network. On-site education operations with local neurosurgeons is our next task in cooperation with national, regional, and continental neurosurgical societies. Organize specialized theoretical and hands-on courses on certain topics, accept residents from the low and middle income countries with merit, and organize live webinars and educational courses. This is already ongoing. Just to show you, this is a basic sets, cranial and spine surgery, and this is basic set for peripheral neurosurgery. Magnification, cranial and spinal, peripheral neurosurgery. So this is not the problem. Monitoring, cranial and spinal, peripheral neurosurgery. This is talking in terms of the title of this presentation. Think global, act local. And the centrality of peripheral neurosurgery is very clear. So peripheral neurosurgery is not limited by technology. So no mastery is born perfect. The art in the skill or the skill in the art. So this is how it looks like when mentee and mentor are suturing vascular anastomosis. And this is a courtesy by our close friend, Jacques Morcos, very instructional video. So we have to have a physical training, not only online training. So digital education is an emerging tool for contributing the spreading information in neurosurgical community. These platforms are consisting of webinars and 3D interactive neuroanatomy platforms. But this is something which is for fast and easy access to digital resources. This could contribute to the promote neurosurgical education in countries with limited facilities. But generally speaking, these are some examples of what is already ongoing, what Professor Franco Servadei promoted in his activities during his term as a president-elect from 2015 until 2021. These are solutions via web that are on our disposal, that we can use this in terms of supporting by WFNS to have an easy communication with and sharing the information, up surgeon also. But the weakness of internet learning is not quality control in some sites. Every surgical approach can be posted even if it requires a long training curve and need for a place where to display approved guidelines and procedures. So use of web technologies, telemedicine, even by phone or for consultation, novel guidelines for patient transfer responsibility and control of the referral neurosurgical centers are already ongoing. These are some, let's say, reminders of what was organized by many educational committees, scientific committees of WFNS during the previous period before the COVID under the leadership of Professor Franco Servadei. This is something which is now we are facing with this in every field of neurosurgery, now in peripheral neurosurgery. This is also in let's say developing process. This was cadaver trials showing that robotic surgery can also be introduced in a peripheral nerve surgery, even nerve grafting, showing nice exposures. But this is also live experience with Oberlin procedure with a Vinci robot from Brazilian group, and some such procedures also for peripheral nerve surgery with nice outcomes in a small series. But this is a high expensive technology, including artificial intelligence, which is an essential part of this. And this is a matter of question how we should find the balance between achievements of the 21st century and low and middle income countries with low resources. So instead of the conclusion, education and transdisciplinarity in peripheral nerve surgery is very important. In peripheral nerve surgery, the learning curve is steep, from basic through advanced to the complex procedure. These are the books published by the WFNS Committee for Peripheral Nerve Surgery during the presidency of Franco Servadei, in which he has wrote a forward for this, supporting our activities in very much. So we know that there are biological challenges versus opportunity peripheral nerve surgery. Nerves regenerate, repair is possible, why results are not better. That is a new concept, and that is the centrality of peripheral nerve surgery. Brain plasticity, and plasticity is ubiquitous. So cutting your nerve, change your brain, and quantum entanglement in these circumstances is to require future studies need to fully understand interplay of individual factors like personality with brain plasticity and potentially develop individually tailored surgical approaches and rehabilitation in patients with peripheral nerve surgery, which requires that we have to work on developing of nerve surgeon specialization, subspecialization. So is the peripheral nerve surgery as important as clipping an aneurysm or resecting a brain tumor or the spine stability? The answer is simple, yes. So this is the WFNS Peripheral Nerve Surgery Task Force Initiative letters which were sent during the presidency of Franco Servadei and also repeated now when the Professor Nelson Lesiku hand over the presidency to the WFNS AC committee and the WFNS Foundation regarding all this, what I was presenting now. And these are the WFNS Peripheral Nerve Surgery Task Force group, members of the group, all neurosurgeons from all over the world, ready to do whatever, everything what I presented and mentioned in the letter, what is sent to the WFNS authorities. Just to remind how it was in the previous times, hoping to face this situation in soon. These are all events that more than 520 courses organized by WFNS committees in 2000 and up to now all over the world. These are the online activities of Peripheral Nerve Surgery Committee with more than 400 registered neurosurgeons faculty all over the world. Also hands-on cadaver courses organized by Peripheral Nerve Surgery Committee with cadaver, excellent education all over the world. And these are, last one was in 2019 before the Beijing in Buenos Aires, and the next one will be next year in Rio de Janeiro. So at the end of the surgeon will be a replaceable factor despite how world would like in 21st century in peripheral nerve surgery, because for one who has nothing, a little is lot. And crisis versus opportunity or challenges versus opportunity, we always accept this as an opportunity, not a crisis.
1 minute more, please.
Yes, yes. So in conclusion, hands-on courses, on-site training with financial support, the foundation and continental national societies and web-based activities should build a bridge between countries with more and countries with less resources. This is our goal, full functional recovery of the patients with lesion of the peripheral nerve surgery. And this is my patient with ulnar nerve schwannoma, complete post-operative recovery, playing the flute and giving a concert. So keep calm and raise awareness of love brachial plexus surgery. I would cordially like to invite you for our next week upcoming 7th annual meeting of Serbian Neurosurgical Society, pure online event. I hope the last one, and of course to the Belgrade Congress, ENS Congress, biggest continental event in October 2022, 16 to 20 next year. Also annual meeting of Serbian Neurosurgical Society next year. And last slide, outstanding, unforgettable event, WFNS meeting in international meeting in Belgrade under the leadership of Franco Servadei, joint venture between Serbian and Italian Neurosurgical Society with huge success and more than 1,000 participants. This is something which we appreciate very much and want to thank to Professor Franco Servadei. Thank you very much for your attention.
Thank you. Thank you, Professor Rasulik. Now we continue with Dr. Atul Gol. Welcome, Dr. Atul Gol. We do not need any words to present you. You are a very well-known world brain surgeon. The lecture is about spinal degeneration, validity of fixation. Thank you, Dr. Atul.
Thank you, Victor. And it is indeed my great honor and big pleasure to give you this presentation. And I take you towards spinal revolution. And needless to say that it is in the honor of my dear friend, Franco Servadei. So the most important thing that makes human body different from other animals is the standing human position. And my basic concept is weakness of the muscles. Throughout life, they make the human body stand. Weakness of those muscles lead to vertical facetal instability. And this is the point of genesis of spinal spondylotic disease. Not the disc, not disc water reduction or disc degeneration, not. It is the muscle weakness related vertical facetal instability. You have heard my concept of basilar invagination, that it is nothing but instability, like lumbosacral listhesis, C1 over C2 listhesis is basilar invagination. You have heard me. So instability is the issue and stabilization is the treatment. More recently, I introduced a very dramatic and probably a revolutionary concept of central or axial atlantoaxial instability, and I wish to discuss this concept. So you please see these slides. This is type 1, where the facet of atlas is in front of facet of axis. Atlantodental interval is increased. There is neural compression. Listhesis is the problem. Instability is the issue and stabilization. No decompression. Now you see this type 2 is facet of atlas is behind the facet of axis. There is no atlantodental interval disturbance. There is no neural compression. There is basilar invagination. This is unstable situation. You need to stabilize. There is no need for decompression. This is type 2. Type 3 is even when the facets are in alignment, presence of Chiari, presence of syrinx, presence of platybasia, and host of other issues are indicators of unstable atlantoaxial joint, and you need to do atlantoaxial stabilization. There is no need for decompression. So this is my concept. Today I wish to discuss with you the concept of spinal spondylosis. The entire literature is disc-centric. Disc is the issue. Disc is the problem. You please read my paper where I relate disc as God, or disc, the prayer of the disc. And I relate the entire issues to human body, to muscle weakness, which relates to spinal spondylosis. Even craniovertebral junction instability or degeneration, not many issues, not many papers have been discussed, but more the mobility, more the degeneration, more the instability. So instability and degeneration are the same terms. Presence of bone in the around the joint and around the odontoid process, reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation. So these are not primary issues. These are due to vertical instability or instability in a vertical parameter. So this buckling is not primary. This reduction is not primary. Osteophytes are not primary. So do not deal with this. Do not deal with the osteophyte. You have to deal with instability, and that is the solution. Bone formation in the apical ligament or osteophyte formation around the odontoid process, bone formation here are not primary. There is no need to decompress. Issue is instability, vertical instability, and the need is to stabilize. So stabilization. Retroodontoid ligament hypertrophy is like osteophyte. This is not primary. This is indicator of atlantoaxial instability. And the treatment is not removing of this, but to do C1, C2 fixation. We introduced this concept for the first time in the year 2004. And now many people in the world follow this concept that retroodontoid mass is like osteophyte. It is secondary. It is protective. And then it indicates atlantoaxial instability. Even retroodontoid cysts are indicators of atlantoaxial instability. There is no need to remove the cyst, and you can have immediate disappearance following atlantoaxial stabilization. We introduce another dramatic concept that retroodontoid pannus is not a primary issue. It is not pathological. It is due to vertical collapse in rheumatoid arthritis. You stabilize and you can have immediate regression of pannus. So there is something primary, which is instability, and something secondary, which is protective and which is natural and which should not be touched. And the more important is it will regress after treatment. So we introduced intra-articular spacers for C1, C2 long time ago, and these spacers are very commonly used in the world of craniovertebral junction surgery. So this is C1, C2 we all talk about, but what about subaxial facets? So we introduced the concept that vertical instability leads to listhesis of the facets, and it reduction in the joint space, buckling of the disc and bulging of the disc and buckling of the posterior longitudinal ligament, osteophyte formation, multi-level buckling are not primary issues. They are secondary, they are protective, they are natural, and they will regress after spinal stabilization. So this is my concept about instability. So in the year 2010, we introduced the concept that you can distract the facet by spacers and achieve arthrodesis, and you can reduce all the issues that are in spondylosis like osteophyte, disc space reduction, ligamentum flavum. Everything can be reduced by facetal distraction. So multi-level disc herniations and multi-level ligamentum flavum, this is immediate postoperative regression by multi-segmental facetal distraction. So my concern is instability, and my aim of operation is arthrodesis. This we introduced in the year 2010 when we said that there is no need for decompression. You introduce spacers, the disc space will increase, the osteophyte will disappear, and the entire spine will revert to normal. Aim is to achieve arthrodesis. So we have multiple cases like this where we have reduced in the immediate postoperative period. Aim is to achieve arthrodesis. More important is the patient recovers remarkably in the immediate postoperative period. So this we published in Journal of Neurosurgery as cover page, and we introduced this concept that listhesis at the facet due to vertical spinal instability is the issue in spinal degeneration. And these were my spacers, and these are heavily patented spacers. Same concept in lumbar canal stenosis, we introduced that it is not stenosis, it is multi-segmental instability, vertical listhesis, and facetal distraction. And this was the article about 12 years or 10 years ago, where we said that spinal stenosis needs to be treated by distraction. So decompression of the compressed neural structures form the basis. Decompression is the key word in spine surgery. I am saying it is absolutely not necessary. So these are the few papers that you will like to read. And my current situation is instability is the issue and only fixation. There is no need for even distraction. And more recently, I published this paper with 215 cases where I said that muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization and no decompression is the treatment. You do fixation, only fixation, and I like transarticular fixation. In 6 months, the entire scenario will change for sure. And without any hesitation, I have to say that all this compression is secondary, they are protective, they are natural, and they will regress after you achieve arthrodesis of the spinal segment. So we have got now multiple papers with multiple patients where we have shown regression of the osteophyte following only fixation. So this is my concept about degenerative spinal spondylosis, that instability is the cause of symptoms and stabilization is the treatment. It is not neural deformation or compression, but instability is the cause of symptoms. So more important is to find out what are the indicators of spinal instability. Like here, if you see, there's 2 segments of osteophyte, but I have fused 4 segments. So adjacent segments were also unstable. How do you find that there is adjacent segment instability during operation on the basis of radiology and on the basis of clinical parameters? And you see the entire thing has regressed and it is more than normal. Multi-level spinal degeneration, I call it multi-level spinal instability. You fuse and you cure. There is no need for any kind of corpectomy, laminectomy, discoidectomy, or laminoplasty. You just do transarticular camelus technique of fixation and you see the wonder. You appreciate, you just listen and see the wonders. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial joint is very commonly associated with multisegmental spinal degeneration. And you see there is type 2 degeneration. So atlantoaxial instability is very commonly present in multisegmental degeneration, and you have to do atlantoaxial fixation along with subaxial fixation and no decompression, and you see the wonders. So this is multisegmental. There is no compression here, but you see there is fascicle listhesis and instability. You have to include this segment in the construct. When there is severe myelopathy in spondylosis, you have to include atlantoaxial joint more often than not. You see, there is no compression. You have to include atlantoaxial joint in cases with severe myelopathy. If you do not include, you may not improve the person. So this is multisegmental, no compression, but inclusion of the C1, C2. Same concept in lumbar canal stenosis. You read the title, analyzing the role of stabilization and futility of decompression. So there is no need for decompression. Lumbar canal stenosis is an evidence of multisegmental instability. This is not primary, this is secondary, this is protective, and this will regress after you do multisegmental stabilization. The thing is, which segments have to be stabilized needs to be understood very carefully. So we have got multiple papers on this subject. What happens to osteophytes after you do multi-level cervical spondylosis? Osteophytes will disappear after 1 year. 100% of cases, you see, osteophytes have completely disappeared. Arthrodesis of the segment, no decompression. So you see similar case I presented earlier, multi-segmental, all the osteophytes are disappeared and the patient is cured in the immediate post-operative period. So is the term degenerative misnomer? Absolutely. What about prolapsed disc? Now my concept is prolapsed or herniated or extruded disc is an evidence of instability. It is due to instability or it causes instability. And you don't need to remove the disc, you only stabilize the segment. So in single level facet disc herniation, the whole world will do ACDF. I am saying you just stabilize, identify the unstable segment, and there is no need to remove this disc in 100% of cases. So this is my article. I wish you read this article in World Neurosurgery where I discuss this concept. Similar in lumbar disc herniation. There is no need to directly remove the disc. You stabilize the segment and the disc will disappear in 6 months, 8 months. More importantly, the patient will dramatically improve in the symptoms in the immediate post-operative period. So we have number of cases like this. OPLL is another complex issue. The whole world is struggling to get the answer to this problem. I am saying that ossification of posterior longitudinal ligament and cervical spondylosis, the cause is the same, instability, and the treatment is the same, stabilization. Only stabilization as the treatment of OPLN, no decompression, no corpectomy, no laminectomy, no laminoplasty. We recently produced our paper in World Neurosurgery with 52 cases, and I wish that you please read this. So when there is multi-segmental OPLL. Many people will do corpectomy, some will do laminectomy, laminoplasty, but I am saying only transarticular cannula, and you see the magic. You see the magic that you have never seen in OPLL. Atlantoaxial instability is very frequently associated with OPLL, and you have to include C1, C2 in your fixation construct in OPLL. There is no need for degeneration. Atlantoaxial and subaxial cervical spinal fixation, can it revolutionize the surgical treatment of OPLL? Absolutely, yes. There is no question and no confusion. There is no need to remove this bone in front of the cord. Dangerous operation, difficult operation. You do this simple, straightforward, quick operation, and you see the magic. So atlantoaxial, okay.
1 minute,
please. Minute, yes. So can decompressive laminectomy for degenerative lumbar and cervical stenosis become historical? Yes. Is instability the nodal point of pathogenesis of both cervical spondylosis and OPLL? Yes. So my concept, which I am introducing in front of my dear friends in the audience and those who are listening to me, introducing the concept, compression is what you see on radiology is never primary, and decompression is never the treatment. Thank you very much, and I wish that you get some newer ideas and you get this beautiful enlightenment about the treatment of degenerative spine. Thank you very much.
Thank you, Professor Atul Gol. The precise time, 15 minutes. Thank you so much. We will continue with Dr. Salman Sharif. Are you ready, friend Salman?
Yes.
Go ahead, please.
Victor, I am ready. I'm just going to share. First of all, again, I'd like to thank my friends in WFNS Anatomy Committee, Victor and Kazadi, who are moderating here, my friends Led and Imad and everybody, and especially Atul, who I'm following. And, you know, it's very difficult to follow when Atul has just given a talk. Yeah, there are some great bits in there, and it's great to see people thinking out of the box and not staying in that. And Atul has always done that, and it's wonderful. He's a dear friend. And we hope someday we can have a joint meeting of our two neighbor countries and have a great time. Well, I'm going to be talking about dorsal approaches to C1, C2, which is again close to Atul's heart. We are honoring Professor Franco Cerveri for his great achievements, Lifetime Achievement Award. We just wrote this article in World Neurosurgery, which is about light at the end of the tunnel, neurosurgery education during COVID. And this was only possible because of all the friends that we have all over the world, along with Victor and Kazadi, who are here as well, and all our other friends. And Atul has been part of this for many of our webinars. So I'm grateful to everyone who's listening. Craniovertebral junction, we're going to be talking about bones, joints, ligaments, nerves, and vessels. Obviously, this talk is not meant for experts. It's meant for our junior guys who are joining us. So this is just a basic concept, how, where, what we should do regarding C1, C2 fixation. So occipital bone, I just want to touch that because sometimes you may need it. Squamous part is posterior and superior to foramen magnum, and basal part is anterior to the foramen magnum. In the condyles, the thick part of the bone is in the midline, and we know this to be remembered when you're doing occipital cervical fusion. We know that atlas or C1 has two lateral masses situated in the anterior medial part of the ring. So you've got short anterior arch and a long curved posterior arch. Foramen transversorium is lateral to the articular surfaces, and there are superior and inferior facets. Superior is oval, whereas inferior is concave, facing upward and medially. And so this all helps us if you have that basic knowledge of what's happening. Axis itself has dense or odontoid process, and they've got two parts, and they've got large lamina, which is bulky spinous process, and this is why this is one of the bulkiest spinous process that you have. It's oval, superior facet articulates superiorly, and inferior is round, and again, same concept, just like the C1. You've got transverse foramen lateral to the superior articular process. The only difference is that it's got slight angle just to give more space to the bending vertebral artery at this stage. Atlantoaxial joints or C1, C2 joints. There are anterior synovial joints between dens and the C1 anterior arch. And then there's a posterior synovial joint between the dens and the transverse ligament. And then there are two lateral C1, C2 joints that we know. Primary motion is rotation here. It rotates 38 degrees to one side, accounting for up to 77% of total axial rotation of the cervical spine. Odontoid act as a pivot for rotation. So if you see here that, you've got C1 and C2, you've got vertebral artery going on both sides. You've got the odontoid peg sitting up there. So I'm just going to move. This is not going to show you anything new here. Ligaments of CV junction, tectorial membrane is important. The LR ligament, the cruciate, the most important ligament, the apical ligament, capsular joints, and accessory atlantoaxial ligament, and anterior atlanto-occipital membrane and posterior membrane. So we're just going to touch the important ones briefly. So you've got the anterior longitudinal ligament, which continues at the anterior atlantoaxial ligament and go up as the membrane as well. So posteriorly, we know that you have got the transverse ligament, and this part is the apical, and this is obviously the transverse ligament going up and down on both sides. You've got, if you look at that, there's superficial layer of membrana tectoria at this stage. And just going to go on to the posterior view. If you remove the lamina, so what we see is that tectorial membrane is the continuation of the posterior longitudinal ligament superiorly above C2, and it covers dens and transverse ligament and attaches to the closed and the medial border of the occipital condyle on both sides, as you can see here. Cruciform ligament, we know, is the strongest ligament available. It's transverse and vertical parts, as you can see here. Its transverse is a thick, strong band that arches across the ring of the atlas and behind the dens. Thicker in the middle and attached to the tubercle on both sides. It acts like a seat belt, and you've got the LR ligament, which are going on both sides of the apex of dens to medial aspect of our occipital condyle, as you can see here. And you can see the joint capsules seen here as well. So let me just play this. So the C2 is highlighted. You've got ligament in nuki that's highlighted. We take that away. Posterior atlanto-occipital membrane, and we hide that away. And then we see that the longitudinal fasciculus of cruciform ligament and the transverse bit, and we hide that away to go underneath. And we see the apical ligament in the center, and you've got the two LR ligament on each sides as well. And once you go in front of that, there is anterior atlanto-occipital membrane. And in front of that, obviously, is the anterior longitudinal ligament that continues this as a part of this. And just going to be showing you the vertebral artery at CV junction. And so it's V3 part of the artery. It is from C2 foramen to the dura mater. And if you see here, so you can see the vertebral artery nicely taken out if we take away rest of the structures, and how it turns, curves, goes laterally, turns around, and then goes over the joint itself and goes through the dura. Posterior approaches to occipital cervical junction. So that's my topic for today, is C1, C2. So we've got indications like type 2 and type 3 odontoid pec fractures, type 2 with oblique fractures in frontal plane with significant displacement and associated Jefferson. Type 2 patients with large kyphosis in barrel chest who we can't approach anteriorly. Type 2 in elderly patients with non-union, pseudoarthrosis after immobilization, and congenital malformations like os and agenesis. So posterior wiring techniques were there, are still there in some countries where you don't have the screws available. Yes, wires can be used, and also in kids, they can be used as well. There is potential for injury to dura and spinal cord itself. Steel wires initially came in, and they were later changed on with the 7-laminar titanium and different kind of cable wires that are available. So Galley came up with this kind of fusion. It offers good stability in flexion and extension. Obviously, when you rotate somebody, then you're unable to hold this, and there's a high chance of non-union. Sontag modified this Galley by creating a notch iliac crest between C2 and wedge under C1. And edge is decorticated, and they recommended halo. Generally, people don't use that rigid collar after this suffices. And if you can combine it with the screws, then obviously you get very good quality fusion. So the only difference is the cable wire goes from inferior to superiorly, and then you bring it around and put a notch around here and fix it, and then you decorticate the bone on both sides, and you have this arched iliac crest bone that is then fixed later on. And it has very good results. So surgical techniques that are available to us, obviously Gold described this direct insertion of C1 lateral mass, and then transdiameter insertion and the notch insertion, which was later described by Lee in 2006. Transarticular screws described by Magrel in 1987, and then we have recently laminar screws and pars and pedicle and facet screws that are available. So we know that the pedicle itself is all the way anteriorly and pars is laterally over here, so screws would be easier to put accordingly. But you have to look at these images of CT and MRI beforehand to know that would it take your screw and is there any deficiency of bone anywhere that can cause problems. So all these measurements were done by our three friends, and Gold's measurements are shown here. Dan's measurements are shown here as well. And the distance between the entry of the vertebral artery and the midline notch was 15 millimeters. So various measurements were taken, and they work nearly always in majority of the patients, except for very bulky or very tiny patients. So posterior C1-2 fusion needs intact laminas. You have difficulty with osteoporosis, degenerative Jefferson's or Hagman, and you can't do that. And clamp position could be applied by hooking onto the superior surface of C1 and inferior surface of C2. Nowadays, many companies are making a hook that comes with the screw at C2 and hook on C1, and it works very well for majority of the cases, and it's routinely used in Europe. So this was the old clamp that we used to use. And then we look at the transarticular screw technique for C1-2, and described by Megrel and Jenere in 1979. And then they, obviously there are disadvantages: steep learning curve, potential complications, screw misplacement, hardware failure, hypoglossal nerve injury, and vertebral artery injury. You need a preoperative CT to look at anomalous vertebral artery. Many people routinely do this, but you have to look at the CT scan carefully to make sure there's no anomalous vertebral artery and the pedicles are large enough to take them. And you have to have a degree of neural compression and transversalar ligament looking at the preoperative MRI. So transarticular screws are easier to put in, but have got complication rate of about 5 to 10% of vertebral artery injury. And so it's important to understand that you need to be wary of that when you're doing this. Entry side to C2-3 facet joint, K-ward inserted 15 degrees medially, and use a fluoro to direct it towards the anterior tubercle of C1. Care avoiding drilling the arch of C1 into soft tissue anteriorly, and you repeat it on both sides, and you need to add that with Sontag wiring as shown here. So C1-2 screw, so you can see that there are different types of screws you can put in, but generally transarticular screw that was described by Magrel obviously had this 10-degree medial angle, and entry point was just at the lower border, midpoint 3 millimeter from the lower end itself. And the important thing to understand is you need to look on the images to make sure that your screw is not going into a non-reduced bone on the top, and you need to be directing it cephaled about 50 degrees, in some cases 40 degrees. So your tubercle is the landmark when you're using it with the x-rays. If you're using image guidance, then it's obviously same stance. So entry point for this has already been described, how we're going to go, 10 degrees medial. And the direction has to be quite steep, as you can see here. And that's the results. You can have something like this. And then we have got another way of doing things. It's C1 lateral mass with C2 pars or pedicle screw. Initially described by Magrel, 79 with lateral mass screws, and Gold and Harm then using polyaxial screw and rod system in 2001 and 2004. The anatomical alignment of C1-2 is not necessary here, so you don't have to be worrying about an aberrant vertebral artery, although you have to see it carefully. The only problem sometimes you could face is significant blood loss when you're putting in C2, the screw in next to the C2 nerve root in C1. It's less rigid than C1, C2 transarticular screw fixation, and this is the big venous complex that you need to be wary about. Many people can sometimes cut the nerve if you have to really go in and put in a cage there, or sometimes if you're an expert like Atul, you might get away with it. C1 lateral mass, obviously there are easy ways of putting it, and there are 3 different ways of putting it, and all 3 are fine. And you've got a technique in which you've got a conventional central dot, which is by Atul, then you've got a posterior notch technique, which is all the way down, and then you've got a technique through directly into the arch itself. You can see what happens is vertebral artery is above, and it's much easier. You can push the venous plexus down, but once you have to open the joints, you have to push this all the way down to put in a spacer to distract. If you look at posterior fixation using C1 lateral mass screws and with the C2 pars, there are disadvantages: significant blood loss, it's less rigid. The 3 different types that of screws that you can put in is goal is a direct technique. Goes straight in. The entry point is midpoint 1 to 2 millimeter above articular surface. Tan used the arch technique, and Lee then described a technique which is a notch technique going all the way into the notch. And all of these work very well. The angles may be slightly different depending on where you're going. Anatomicalization of C1 lateral mass, and the important bit is to remember that we've got hypoglossal and carotid in front, so you cannot be coming out here. And you need to be remembering that you've got this 22 degrees of angle. So if you're coming in with your screw, you don't want to be coming out here looking on your x-ray that you are on lateral x-ray fluoro, that you're fine, but you may be going anterior to this. So you have to be wary of these vessels and the nerve in front. C2 par screw is between the superior and inferior articular process. The trajectory is similar to transarticular screw. The only difference is these are short screws. And you can see the dotted line here. These are short screws, and your angulation is again steep. So 10 degrees medial angulation, and screw is generally 16 millimeter. Whereas C2 pedicle screw connects the dorsal elements, and it's anterior to the C2. So pedicle is here. The entry point is right all the way lateral in the pars on the superior margin of the C2 lamina. And the
1
point
minute,
is,
please.
yeah, sure.
1 minute.
Yeah, I'm wrapping up. Don't worry. Posterior fixation using the C1 lateral mass with C2 pars or pedicle screw. Again, the same thing that we have already discussed before. And you can see the pedicle screw entry points and the direction, and 30 degrees Feld and 40 degree medial with the pedicle screw. Laminar screw are much easier to put in. Have been described many times, and describe them in detail. They've got same kind of biomechanic purchase. So they should be used more often, and I use them routinely in nearly every case, because the risk of injuring any vertebral artery or anything else is minimum, and you can then easily put you can easily constrict this and then cause all the decompression that you need to make for something like Bazarine invagination. Occiput, I'm not going to go into it because that's not we are not talking about that at the moment. But all I'm going to say, choose wisely, as Yanni et al. Described in 2010. Use the laminar screw as often as possible, so you keep it safe, and try not to use the transarticular screw unless you're an expert. So par screw is much safer, or a laminar screw is much safer generally in C1, C2 area. So I thank you all, and it was wonderful seeing you all, and hope to continue seeing you in real time soon. Thank you.
Thank you, Dr. Salman. Please, Kasadi Kalangu. You are mute. Kasadi, you are mute.
Here we are. Okay, can you hear me now?
Yes.
Okay, thank you very much, Salman. It's wonderful lecture, and thank you very much for the other presenters as well, Atul, Lucas. I enjoyed it. It was fantastic. Now, I'm going to call our friend Victor. Everybody knows him. He's fantastic with his model of anatomy, and we enjoy them, and they're fantastic. So he's going to talk to us about vascularity of the lumbosacral segment of the spinal cord. Okay, Victor, go ahead, please. Thank you.
Thank you so much. Can you see all the screen?
Yes, I can see. Not all. Yes, I can see.
All the screen. Thank you. Thank you.
Not the complete screen.
Not the complete. Okay, let me share again. Now? Now
Yes.
it's okay? Okay, thank you. We are going to review the vascular anatomy of the lumbosacral spinal cord. Thank you very much to Vlad and Naimad to allow me to present this the anatomy of the spinal cord. Here we have the posterior aspect of the lumbosacral spinal cord. In both sides, we can see the posterior spinal arteries, and in the center, the great posterior spinal vein. So it was Albert Adamkiewicz who did the first research about the vascularity of the spinal cord. This is a drawing obtained from an original article by Adamkiewicz in 1881, showing arterial vasculature of the spinal cord and the bidirectional flow of fluid in the spinal cord vasculature. Here we can see.
We don't see the whole screen. Sorry, we don't see the whole screen.
Okay, okay. Let me see. Now.
Now we see. Yes.
Oh, okay. Thank you. So in this drawing, we can see the Adamkiewicz artery and bidirectional flow to the upper and the lower side. So this is a picture about the lower end of the Adamkiewicz artery. This is the anterior aspect, posterior aspect. Adamkiewicz injected arteries with carmine sediment of the red color for arteries and Prussian blue for veins. So the difference between those times with now is this. We can now inject in fresh specimens color blue for veins and red for arteries, and we can get these pictures. Spinal cords were extracted via longitudinal midline posterior incision from the occiput to the sacrum. Anatomic dissection was performed until reaching the vertebral lamina. Laminectomies were performed from C1 to L5. The spinal nerves were cut with care so as not to lesion the dura. In this picture, we can see the rachidius canal, and here we have the dura mater covering the spinal cord. So this is an injection of red natural latex into the Adamkiewicz artery under moderate pressure and close visual inspection to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels. As you can see here, with this technique, we can inject very small arteries around or less than 200 micras. The great anterior radiculomedullary artery is located in the anterior aspect of the spinal cord, where it took a characteristic head pain. The preoperative localization of this artery is very important in the surgical transthoracic spinal procedures. Here we have a picture about to show this beautiful artery, the Adamkiewicz artery. This is a close view. The artery of Adamkiewicz was present in 45 specimens in the left side and in 5 specimens in the right side. Here we have a picture showing the origin in the right side. This is another picture in the left side. Here we have the lower part of this artery. And if we displace the anterior spinal nerves, we can see the conus medullaris and the end of this Adamkiewicz artery. This artery trifurcates. One artery is going to the filum terminal, and the other 2 are going to each side of the spinal cord to the posterolateral, where it get the name of posterior spinal artery. So this is another picture to show some variability in the anatomy of this Adamkiewicz artery. This is the aspect of, in the superior part, we have a thoracic artery, known also as von Haller artery, and the difference between the Adamkiewicz artery. The preoperative localization of this artery is very important in surgical transthoracic spine, and the anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. In here, we have the highest level in these 50 spinal cords studied. And here we can see the 1, 2, 3, 4, 5, 6, 7, and 8 cervical spinal nerves, and then 1, 2, 3 thoracic nerves. So the origin of this artery was T3 in the left side. And we don't have contributors in the thoracic segment, just this artery. So this is a close view of this Adamkiewicz artery arising from T3. And this is the lowest level of this Adamkiewicz artery. This is arising from left L2 in the lumbar nerve root. We have this, and if we displace this anterior spinal nerves, we can get a very nice picture showing this Adamkiewicz artery and the posterior aspect. This is the lateral aspect and posterior aspect of this spinal cord. Here we have the Adamkiewicz artery giving rise to this posterior medullary spinal artery. This is the most common origin of this Adamkiewicz artery in the left side, and the T9, T8 to T10, specifically in T9, 13 specimens. So here we have two Adamkiewicz arteries, and we are going to see the anatomy of the great posterior radiculomedullary artery. Understanding the basic vascular anatomy of the spinal cord is of utmost importance for imaging interpretation and endovascular and surgical management of spinal cord vascular malformations. Advances in diagnostic and therapeutic interventions have led a need for more detailed and specific understanding of the microvasculature of the spinal cord. In particular, attention to the anatomic variations of the smaller caliber circulatory supply to the spinal cord allows tailored management of a specific patient. Here we have a posterior aspect of this spinal cord, and here we can see this great posterior radiculomedullary artery. The anatomy of the great posterior radiculomedullary artery was denied for several authors, although various authors postulate such vessels. Guillain, Lasortz, Jellinger, and others do not mention it or even deny its existence, like Domis in 1980. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels, diameter 350 and 500 micras. Here we have this beautiful artery, and there is no doubt about its existence. Here we have a small video.
Radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. Then returns to the posterior aspect between L3 and L4 nerves. Here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery. This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery. So this artery was identified in 72% of spinal cord specimens. This total included specimens in which unilateral and bilateral GPRAs were found, as well as a single case in which 3 GPRA were evident. In 22% of the specimens, bilateral GPRAs were present. Great posterior radiculomedullary artery. One specimen demonstrated 3 right-sided GPRAs, and the distribution of this beautiful artery is in this table. The most frequent in T12 in the left side, and in the right side also 9 arteries. So there is no doubt about the existence of this great posterior radiculomedullary artery. Conclusions: a GPRA is conclusively present in most 72% individuals. Understanding this intricate anatomy and its variations is critical for addressing vascular malformations of the spinal cord. So about the veins, I want to show you this injection of silicone color blue to fill the posterior spinal veins. So now I am working in to find a classification of these veins in the posterior and anterior aspect of this spinal cord. The great spinal anterior vein, as you can see here, the average is about 0.8 millimeters, and this vein could measure between 46 microns to 1.3 millimeters. So the variation, this is a variation of this posterior spinal vein. The measure of this was almost 1.5 millimeter. And as you can see here, the anatomy is intricate as I can show you in these pictures. I had the opportunity to publish this work in the American Journal of Neuroradiology. And to finish this lecture, I want to invite you next year. We are organizing through the National College of Neurosurgery a congress in Acapulco on May next year, and another one on November 16 to 19, and all of you are invited. Thank you so much.
Thank you very much. Thank you very much, Victor, for this wonderful, wonderful lecture and for keeping the time. This is really a beautiful anatomy to know, particularly when you are doing spinal surgery. Let me call my friend Amir Sami.
Yes, hi, Kazari. Can you hear me?
Are you there? Oh, Amir, how are you?
Hi, great, thanks.
Good, okay. I think everybody knows you. There is no need to introduce you. You are very famous. Okay, Amir, you are going to talk to us about resection of intradural spinal tumors.
Yes.
Please go ahead.
Can you see my shared screen now?
Not yet. Yes, you can see the share screen, but not the big screen.
Now?
No, not yet.
You can share again and
Now
the full screen is going to appear.
Oh, perfect. Now it's perfect.
You can see it. Okay, great.
Yes, I can see it now.
So first of all, I'd like to thank you, dear Kazadi, dear good friend, and of course, Vladimir Benesh, Imad Kanan for putting up another wonderful webinar with their committee. And of course, it's a pleasure to know that we are honoring our friend and past president of the Federation, Professor Franco Servadei, for his great achievements. I have been serving with him on the AC, and I can only say he was really working extremely hard in this position, trying to hear and listen to all neurosurgeons all over the world and to consider as much as possible everybody's opinion and voice. It was a privilege to work with him, and my congratulations to his presidency. Now, my topic is resection of intradural spinal tumors, and I have no disclosures. These are my presentation items. Well, the epidemiology of these tumors, these are rather rare tumors, 1 to 3 in 100,000 patients, mostly extramedullary tumors, 51 to 54%. Some of them also dumbbell tumors with intradural and extradural extension. And then we have the purely intramedullary tumors that my friend Keke Torel will be talking about, 15 to 18% of these tumors, and they represent about 2 to 4% of all CNS tumors, actually. So this is our Hanover series with about 635 adult patients, where you see that the majority of these tumors are extramedullary tumors, then followed by the intramedullary. And within the group of the extramedullary, the majority are purely intradural tumors, and then we have the intra and extradural tumors. So most prevalent tumors of the intradural extramedullary tumors are meningiomas and nerve sheath tumors in our series. You see that in the meningiomas, only 10% show an extradural extension, while in the nerve sheath tumors, you see it in 35% of the patients. And the meningiomas are most prevalent in the thoracic region, while the nerve sheath tumors in the cervical and lumbar region. And then you see many of the other possible diagnoses of tumors in that respect. Intradural and intramedullary spinal tumors are mostly ependymomas, followed by astrocytomas, all mostly in the thoracic region, followed by the cervical region. These are the further differential diagnoses you can see. And then you see now that often we see a syringomyelia associated with intramedullary tumors. So if we look at the different types of tumors, we see that in hemangioblastomas, in 86% of the cases, we see an associated syringomyelia, ependymoma in 61%, and astrocytoma in 29%. And if we look at the incidence of syrinx in relation to the spinal region, we see that they are most prevalent in the thoracic, followed by cervical and the conus region. Looking at the different clinical presentations and symptoms of the patient with intradural extramedullary, intra-extradural extramedullary, and intramedullary, we see that in these intramedullary tumors, most patients have hyposthesia, motor weakness, and consequently gait disturbance also, and that in the extramedullary tumors, pain is the most prevalent symptom, followed by hyposthesia and motor weakness and gait disturbance. So once you have a diagnosis of intradural spinal tumor, you need an interdisciplinary tumor board where you discuss the case in order to exclude inflammation, demyelinating disease, and vascular lesions. So you want to avoid to operate into an inflammation or demyelinating disease specifically, and you should identify syndromic tumors, metastases, and malignant tumors, because this will then define the further diagnostic and therapeutic paths. And in some of these tumor, genomic guided precision oncology treatment options are also available. So the surgical planning is evident, of course, the clinical assessment, neurological assessment of the patient, if possible, of course, neurophysiological documentation prior to surgery. Very important is to have a CT and X-ray inflection extension, and if possible, also whole spine in standing position for evaluation of the sagittal balance. This is important in order to understand if there are some instabilities, etc., which need to be considered for the approach. If we look at the approach, the intradural, intramedullary tumors are mostly operated through a laminotomy, which I will be showing in a moment. The intradural extramedullary tumors are mostly operated with a hemilaminectomy and with or without foraminotomy, depending if there is a lateral extension. We need to avoid postoperative instability. In selected cases, an additional stabilization may be needed. Well, the earlier the surgery is performed after onset of symptoms, the better is the neurological prognosis regarding recovery. In intramedullary lesions, the tumor-induced neurological deficits do often not recover, while surgery-associated motor deficits are transitory and do mostly recover. So there is no rationale to delay surgery once the diagnosis of such a tumor is confirmed. Exceptions are syndromic tumors like in NF1 and 2 patients. Here, only growing tumors that are increasingly symptomatic shall be considered for surgery. The aim is to preserve, obviously, quality of life as much and as long as possible and to avoid irreversible deficits. I will skip these details for the tumor resection due to time. And let's have a look at the results. Radicality of resection in the intradural extramedullary spinal tumors. Those who don't have extradural extension, a radical resection is more frequently possible, while in those with intra-extradural extension, in neurofibroma especially, where you may not be able to discern then between motor fibers and tumor in the cervical region or thoracic region or lumbar region, radical resection may not always be possible. Therefore, we have a higher subtotal resection rate. So results in intradural extramedullary tumors, we see that following complete tumor resection, all preoperative symptoms show a significant improvement in more than 90%, so very gratifying for the patient. In 10% of the patients, we have transitory neurological deficits, permanent neurological deficits in 2%. Main postoperative complications are CSF leak in 4%, wound infection, urinary tract infection, instability only in 1%. So in surgery of recurrent tumors, radical resection rates are lower and complication rates are typically higher. If we look at the sensory function in intramedullary tumors, we see that this deteriorates slightly following surgery and does not recover fully even after 1 year. This is specifically approach related, while the motor function typically, if it decreases initially after surgery, recovers after 1 year at latest to the preoperative level or even improves. So this is the Karnofsky score, which is also good after 1 year. What should be avoided are these long-term complications with instability. So this is what you don't want, a case with a multi-segmental laminectomy, partial removal of the tumor, and afterwards a tethered cord in the patient. So this is definitely something that should be avoided. Some techniques to minimize the risk for tethered cord are pile cord sutures, meticulous hemostasis, and duroplasty if necessary. I show you now one case of an intradural extramedullary ventral tumor at the level of TH4, 32-year-old female who had a progressive deterioration, first just pain and sensory deficits, and just a month before admission also gait disturbance. Here you see the tumor that has 11 millimeter in the AP direction, is compressing the spinal cord to a diameter of 2 millimeters here. This again, the pre-op images, sagittal view and axial view. And this is the surgical approach through a hemilaminectomy, as you can see here. So I will go step by step, opening of the dura, then arachnoid dissection, And you see, if you have a good partner, you can do a 3 or 4 hand dissection of the tumor and the arachnoid, and then you can also perform here an arachnoid suture that will support you in the surgery. Here is the suture that is taking away the spinal cord, opens the space, and then you can start a piecemeal resection of the tumor after opening the capsule. And this can be also added here with a micro ultrasound aspirator in order not to pull too much on the tumor. So stepwise resection, and eventually then you can expose the different poles of the tumor. As you can see here, mobilize the tumor all through the hemilaminectomy and keep the spinal cord safe. And then eventually this tumor turned out to be, interestingly, a neurinoma. So the dissection of the tumor from the surrounding nerves. Here, the tumor mass is removed, and then we can see how the tumor is originating from a nerve root and then can be dissected stepwise. So this is then the closure of the dura. The SSEPs have even improved at the end of surgery. Here you see now the pre-op and the post-operative image a few days after surgery with the spinal cord completely again in position and extended. And the patient has improved tremendously. This is a 44-year-old male with increasing pain in the left thoracolumbar region. MRI suspicious for neurofibroma. Diagnostic MRI workup shows multiple regional here small tumors. So this was thought to be a segmental neurofibromatosis. Here you can see also how the tumor is compressing the pleura. So through a hemilaminectomy with a unilateral facetectomy, we could remove the tumor here, as you can see, and it turned out to be a neurofibroma schwannoma hybrid nerve sheath tumor, which was first introduced in 2016 in WHO classification. Here you see the neuronoma with the neurofibroma. It's a rather rare tumor, but there are pharmacological treatments even for such a tumor that may, if in case he develops more and they are partly inoperable, that would be an interesting option for the patient. Here you see again the preoperative image and the postoperative image after tumor removal. This is the last case I show you. This is a 46-year-old patient with an intramedullary tumor in C5-6, clinically a progressive tetraparesis and gait disturbance. This patient had in his history actually a thyroid carcinoma. So here you can see that this tumor has bled, and this is the laminotomy we have performed. This is then the dura. I will try to keep in time, so I forward a little bit. And dural opening, we can see the shining of the blood through the, oh, sorry, this was too fast. Here we go. Midline opening, and then exposure of the tumor and stepwise resection of the tumor, mobilizing with gentle dissection, especially towards the spinal cord. Inspection of the cavity, dural suture, and then you see here quickly the laminotomy and how we fix the lamina back with these microplates. And this is the patient after surgery who is in good shape. He has also improved his motor skills right after surgery. And MEPs have also improved, and this is before and after surgery, the MRI, and below you see here the laminotomy before and after.
1 minute, please.
In the past, there was a great reluctance to operate on these patients because of the fear to create additional permanent neurological deficits. In the last two decades, thanks to improvement of microsurgical techniques and neuromonitoring, low morbidity and low complication rates can be achieved as demonstrated. In the majority of these tumors, radical resection and clinical improvements achieved. And since most of these tumors are benign, the patients are cured. Therefore, the treatment of intradural spinal tumors is nowadays a most gratifying type of surgery. Given the relative rarity of these tumors, spinal surgeons shall receive training in specialized high-volume centers in order to learn the established surgical concept for treating such lesions. The first surgical intervention of intradural spinal tumors carries a great responsibility for the patient's future, since surgery of recurrent tumors tend to carry lower chances for radical resection, have a greater probability for complications. Thank you for your attention.
Thank you very much, Amir, for this very interesting and nice lecture. Let me introduce, we discussed that later on. Let me introduce my friend Keki Turel. Is he around? Keki, are you around?
Yes,
who will going to talk to us about microsurgical anatomy and treatment of spinal intramedullary tumors. Keki, yes, the floor is yours.
Yes, thank you very much, Kazari. Thank you. Thanks to Imar and my friend Menez, Vladimir, for giving me this opportunity. I am extremely honored and delighted, particularly because this series has been specially made to honor our great friend, the past president, Franco Servidai, with whom we had an amazing friendship. So let me start by saying namaste. And I would say that we are all one, in short. And so this is honoring Franco Servidai. And the two of us are sharing the common seat in one of these WFNS webinars, or seminars rather, physical seminars. And here you can see us with Grogi and his good friend Amar, who also gave a great personal tribute to Franco yesterday. And I chose this subject, before I even say this, I must personally thank Franco for not only his great hard work, but also for having this great vision of establishing a new committee on complications in neurosurgery. And I'm really honored that he took my work on this area very seriously and established for the first time in the WFNS a committee specially devoted to complications.
Sorry to interrupt. Your slides are not seen.
Yes, my slides are not seen?
Yeah, not seen. Except that Namaste slide, nothing is seen.
Oh, really? I'm so sorry.
Namaste slide.
Thank you for drawing my attention. So start from the beginning. Start from the beginning. Yes. You can now see this namaste.
Yes.
Yes.
Why is it not moving here? It should
Now
move.
it's
Okay.
moving. Yeah.
Yes.
It's okay.
You can see this?
Yes.
Okay, so here we are sharing the seat together as we are traveling in some seminar and here at a dinner function with our good friends some time ago. I chose this subject because I know Franco's great interest in spinal cord surgery and also my personal great interest in spinal intramedullary tumors. So I'm going to briefly run through the anatomy, which Victor, as I'd already covered very brilliantly, he spoke specifically on these radiculomedullary arteries, anterior and posterior. But I shall talk to you on the spinal cord very briefly. The cord is about 18 inches long and just half an inch thick in the cervical and quarter-inch thick in the thoracic area. Can you imagine how thin the cord is? Just the size of your little finger. And when you think about that anatomy, you wonder how such a huge tumor could be accommodated. This is a tumor I removed about 10 years ago from C2 up to D4, D5. And it's about 24 centimeters. So it's more than half the length of the spinal cord and much more than 3 times the width of the spinal cord. And imagine the amount of spinal cord expansion that can occur and the huge plasticity, neuronal plasticity which it has, because this patient who came in paraplegia not went home, but he recovered over some months to once again be on his feet. And I'll show this to you later on. It's very important to know the anatomy. I know all of you know it, but it's very important for me to re-emphasize that posterior columns are the sacral and the lumbar segments are the closest to the midline. And because we talk about midline myelotomy for entering into the spinal cord, these are the areas which are maximally affected. And therefore, if you are not strictly in the midline, and if you damage either one or both, you would result in huge amount of posterior column deficit. That means even if the motor capacity is intact, he may not be able to walk because of his posterior column loss. And therefore, these intramedullary tumors come quite often with gait disturbance because of the posterior column loss. They may also come, if it's a cervical tumor, they will come, the first motor tracts to be affected will be cervical, and the last will be the sacral. And therefore, there is a sacral sparing. In a large intramedullary tumor, initially you can have affection of the cervical and then the dorsal, and then there's eventually the sphincters get lost at the end. The same applies to these spinothalamic tracts in terms of clinical neurology. The vascular anatomy is formed, the two anterior spinal arteries, they form the single anterior spinal artery arising from the vertebral artery. And there are about 7 to 14 radicular branches which merge with the anterior spinal. And most of the cord, cervical cord, is supplied from the vertebral arteries. But segment C7 to T2 receives supply from the branches of the inferior thyroid or costocervical trunk. We already heard about the below T2, the cord is supplied by vessels rising from the aorta or the internal iliac. And we heard about the Allen-Quois artery from Victor Hugo, so I won't dwell much into that now. The posterior spinal arteries are relatively small, and they arise directly from the vertebral artery or occasionally from pica. And in the upper cervical, they are situated along the medial edge over here of the posterior roots. But then as they come to mid-cervical, they arborize, they meander, they give off something like plexiform vessels that are filled. And these are the vessels we see when we are operating on the intramedullary tumor from behind. Also important are these segmental vessels, what we call as the sulcocommissural arteries, which I'll show you in my surgical videos, running from the lateral and the anterior sides of the spinal cord. There are as many as 200 altogether, and they ride from the anterior spinal artery, fewest in the thoracic and most numerous in the lumbar region. And they arborize in the anterior and intromedial gray horns. So this is the schematic appearance of the vascular supply of the spinal cord, a single anterior spinal and dual posterior spinal and several segmental arteries or sulcocommissural vessels. So outlook towards the spinal intramedullary tumors has changed considerably with the advent of microsurgical techniques and neuromonitoring, and total excision, of course, is now technically feasible and compatible with good neurosurgical or neurological recovery. Until 2018, I had a series of 300 odd cases, and 80% of them were malignant cord tumors. That means astrocytomas, ependymomas, and so on, and 20% benign. So most of these patients had several segment involvement, very few, 1 to 3, but mostly 4 to 7, and then 8 to 11, and 12 to 7, 16 segments involving. So about 60% of our patients had tumors involving 4 segments or more, and every 6th patient had more than 8 segment involvement. This is our series. Syringomyelia, which Amir also spoke about, can be there in astrocytomas, can be in ependymomas, they could be proximal to tumor, distal to tumor, and they can be both proximal and distal to tumor. And we also have sometimes intratumoral syrinx. So we have this, for example, this spinal cord tumor over here, who had above D8, entire spinal cord was having a syrinx. And the neurology can be representative of this cervical cord pathology because of the syrinx. And then after surgery, we don't have to operate on the syrinx, we just remove the spinal cord tumor. And after removal of the syrinx, the entire syrinx collapses and the whole spinal cord becomes quite uniformly intact. So philosophy of management assume that majority of tumors are benign and resectable. Assume that goal is our long-term control or cure with preservation of function. Avoid MRI histological prediction. You can biopsy during surgery and confirm it, but gross determination of tumor cord interface is the most important principle governing removal. And these are the surgical steps. The exposure of skin laminae, myelotomy, we always do a laminotomy and laminoplasty. Myelotomy is usually in the midline, except a rare occasion when the tumor is migrating to one side. Pile stay sutures, gentle dissection to find the plane of dissection, stay in the same vertical plane, minimal use of bipolar or almost no use, preserve all vessels, arteries and veins, copious irrigation, and therefore you require a very good assistant. Closure of pia may not be possible, but arachnoid can be sutured or it can be welded. I'll show that to you also. And final closure is cord, dura, laminae, muscles, everything brought back into the system. So this is a post-laminotomy, laminoplasty using titanium mini plates to restore the spinal cord anatomy, spinal column anatomy. The spinal cord exposure may be in the midline or it may be in the lateral at the root entry zone. How do you identify the midline? This is the most crucial first step, midline myelotomy. The sulcus is a shallow groove between 2 posterior columns. You may see this over here, but not always, because the tumor may expand the spinal cord so much that the midline myelotomy may not be, the midline sulcus may not be visible. So sometimes you can see it, as you can see over here, or in the next. If you cannot see it, then you measure the distance between the 2 roots on the 2 sides root entry zones, and then you measure it and make a rough halfway midline conformation. But the surest conformation sign is the presence of sulcocommissural vessels which are dipping in. So you can see the midline over here and you can see the sulcocommissural vessels dipping inside. And remember, this midline myelotomy, as I said, posterior column impairment is one of the most important causes for inability to walk. One can compensate for motor weakness, but not for the loss of joint position sense. Incision is made directly over the lesion. Sometimes it is indicated over the exophytic lesion in the subpial locations like a hemangioblastoma. So you have the exposure of dura and you have the spinal cord on the right-hand side. You can see the posterior cervix, posterior spinal artery, and you can see the radicular vessels supporting it. This is neatly split and posterior columns are preserved by a midline myelotomy. Very clean, you can see the midline very nicely over here and over there. The technical principles of tumor removal are adequate bone dural exposure, myelotomy, as I said, over the entire extent. I sometimes extend the myelotomy beyond the extent of the tumor so that I can have an area where it is absolutely intact, and from there I proceed into the tumor. And then you identify the tumor surface, identify rostrocaudal poles or cysts. As quite often you find a cyst at the pole, and that's a very good way to enter the lesion. Pile traction sutures, where you require 4 hands, biopsy, develop a plane, traction, counter traction. If feasible, try to remove in toto. I'll show that to you. Most of the time, I fancy doing it in one mass, but internal decorporation may be required. CUSA for debulking, therefore. Intraoperative USG for locating very small tumors which may cause insignificant cord expansion. So ultrasound, very useful. This is a handy probe. Intraoperative monitoring, as you know, is very important. MEPs, SSCPs, and the D waves. And that's what we are doing during the operation. I'm sitting and operating on this particular case. Pile closure, whenever possible, to restore the cord shape. It may not be always possible or not be always advisable in high-grade gliomas or swollen cord, but arachnoid is always possible. I used to initially close with proline, but now I can simply solder it by holding the two ends of the arachnoid and just apply gentle bipolar, and arachnoid is closed. The dura, of course, is always closed watertight, except when the spinal cord is swollen due to a very high-grade astrocytoma, in which case we have to do a duraplasty, lax duraplasty. I'll show you a couple of cases. 48-year-old gentleman is a doctor, medical doctor, who had this tumor over here, and here it is. You can see the video. All right, the video is gone.
Yeah, you stopped and skipped.
Okay, so there's a midline myelotomy. Taking care, first of all, you have to open the arachnoid, and then you identify the midline and gently separate with two dissectors. Whenever you see vessels crossing, you can lift up the vessel and mobilize it. I do not coagulate the vessels. Sometimes I do a skip myelotomy. That means I keep the vessel in the midline and then move above and below it and continue dissection, remain in the midline, identify the tumor, separate the tumor, picking it up from the rest of the spinal cord, coagulating the vessels as they enter the tumor, not on the spinal cord surface, only on the surface of the tumor, moving it from side to side and from below upwards, rolling it. And you can see how nicely and how easily the entire tumor comes out. And this is the tumor lying on the spinal cord surface. And that's the postoperative. And that's the patient. You just answer this, please. Okay, all right. Ependymomas are midline, well circumscribed, and therefore dissectable from cord matter and can be completely excised. You'll see this ependymoma here, right from the medulla, going up to the upper dorsal cord. And on the right-hand side, post-surgical, microsurgical removal. So this is the patient pre-operation. You can see how lean, how wasted he is. He's not able to move his legs. His upper limbs are also weak and wasted. And post-operative. This is the operation. Identifying the midline again. There's a cyst which I thought would help me to enter the tumor. So I go from the upper cervical region and then I start dissecting. However, I find that at this place, there seems to be some kind of a irregularity of the lesion and the separation becomes a little risky. So then I go down to the lower pole. Identify the lower pole of the spinal tumor, pick up the lower pole and gently mobilize it from the, so I usually pick up one pole or the other, either the cephalic area or the dorsal or the caudal area. So here you can see me picking up the lower pole and the entire tumor is now being lifted, separated from side to side and from below upwards. You see how easy it is to develop a plane. And it's a huge tumor, as I told you, from the medulla up to D2, D3. And this is the whole tumor after it is being separated, lying on the cord, and entire tumor removal. Immediate post-operative, there might be expected some degree of weakness, but post-operatively, you can see him neurologically absolutely intact. You can see the pencil tilt cord on the right side, but you saw the patient walking absolutely fine, zero deficit. Okay. Astrocytomas are mostly spinocytic. tend to be eccentric and patchy, not always possible to remove completely, especially the high-grade ones. MRI cannot be helpful in distinguishing the operability. You should just expect that everything will be operable and go ahead and do it. Debulking may often suffice. Preserving quality of life is most important. Malignant gliomas, no cure, only palliation.
1 minute, please.
So this is the pyrocytic. All right, if it is only 1 minute, then I have to rush. So I have to. So this is following the same principle. Here you are. That's a hemangioblastoma. I will have to skip the video. Total removal. This is a preoperative MRI and postoperative MRI. Look at the spinal cord, how swollen it is, because hemangioblastomas have massive edema preoperatively, and that sometimes is the best way to make a diagnosis. And that's the postoperative, very well, fully recovered, young man from Kashmir. Epidermoids, well circumscribed, completely resectable from cord matter, and sometimes the capsule may be adherent, and that may be left behind, as you know, even in the brain. So I will skip this also because it is time is up, but postoperatively she does quite well. All right. Okay. So this is the last case I would like to show you in 1 minute. Gentleman who was in a wheelchair for 3 years almost, progressive corticoparesis and tumor going right from C3 up to D6. And he was refused surgery from several centers. That's why he went from place to place, finally came to me after 3 years of wheelchair existence. His upper limbs were also very weak. And so I start again doing the full myelotomy. I always extend the whole myelotomy, and I go sometimes one level above and below, cephalic and caudal, and pick up the tumor from the pole, from one pole, and then start dissecting it out and separating it out. You can see the whole tumor. I like to remove tumor in one piece if it is possible. I do not think it's necessary to use CUSA. I enjoy this kind of separation like a benign tumor, completely separating from the cord. This was done something like 10 years ago, and so the quality of the video is a VHS cassette, which has been transferred. It's not a high definition video. Nonetheless, it's a complete tumor removal. And at the end of the tumor, this whole tumor looks like a huge sausage. You can see in one piece. And finally, I go to the upper pole, starting from the lower to the upper pole, separating all the, and you can see this whole tumor coming out in one piece. You can imagine now how such a large tumor can be accommodated in such a thin spinal cord, which we say is just half an inch in diameter. So this is the amazing neural plasticity. It just expands, and in spite of which, so this is the tumor I showed you right at the beginning of the presentation, and postoperatively, his whole spinal cord, he was only kept ventilated overnight. The next day he was off the ventilator. His upper limbs were brilliant, although he was very weak in the pre-op phase. And then he's sitting here with his own tumor. He's still in the wheelchair when he left the hospital. But you can see his upper limbs have now fully recovered 9 months. 9 months post-operatively. And he started moving his legs.
Dear friend Keki, we are on time. Thank you.
And now, 5 years post-operatively, he's moving his legs very well. Okay, and he's now walking, which is impossible to believe, considering that a man was paraplegic for almost 3 years. So, dorsal and conus regions are less favorable. On the contrary, cervical and cervicomedullary tumors are extremely resectable. Number of segments do not affect the degree of resection or the outcome, and chronicity of symptoms tend to relate to poor outcome. Therefore, very large and very small tumors. You must be careful case selection, respect anatomy, be patient, never forget quality of life. Veins may cross from one side to the other. Try to preserve them. Anterior spinal artery supplies the tumor at its depth, must be preserved. Thank you very much for your very patient listening. Thank you.
Thank you very much, Keki. I think we have completed the first session of the day. I don't know, Imad, you would like to lead for the questions or?
No, we are not complete. Actually, Professor Najia is going to present her presentation
Oh, sorry.
on the program.
Oh,
and she will
okay.
talk about brainstem.
Okay, excellent. That's fine. Please,
So,
Najia, are you around?
Thank you, Kazadi. I know that I disturbed the program because tomorrow
Absolutely
it's
not. Absolutely not.
in Morocco, and I should be available for all the day. This is why I asked gently Imad, and he moved my presentation today, even if it's not about the spine.
No problem. No problem. Thank you very much.
So I'll try to share my screen. And first of all, let me thanks all the two, of course, resident of the chairman of the committee of this wonderful committee. He did a tremendous job during this mandate, and I think one of the maybe I hope that it not last, but one of the more important is to, of course, he tribute to our last president.
Najia, we can't hear you.
Of course, the to work with him. Sorry.
the audio, Najia, is not very clear.
Yeah, I'm so sorry because I share my connection with my mobile, and okay, I will fix the problem. So it's my pleasure and honor to be, of course, one of the guest speaker today in this wonderful meeting. And again, thank you to all the speakers. Thank you, of course, to the chairmen and the chairman of this session. And again, thank you to our last president. I'm sure that he will continue with us for a long time. And what he did, it's a really very, very nice job. And he was connected all the neurosurgeons around the world. So my talk today is about, let me first to show you my country. All of you, I think all of you, you know Morocco, and the capital of Morocco, a meeting in a person, but we will. I hope we will make it possible, at least virtually or in person, in a few months when this pandemic will be over. So my talk today is about the brainstem cavernoma, how to manage this type of cavernoma in this location. It's a challenging, of course, fields, and we need to have a minimum of tools to achieve this this removal of the type of cavernoma in this location. So the first case of surgical brainstem cavernoma with favorable evaluation was published by Dandy in 1928, but it is only in the last decade the successful microsurgical series are reported in the literature with a decrease in morbidity and mortality, and with at least acceptable rate. Actually, the natural history is better known, but the brainstem cavernoma is still subject of controversy because it is a highly functional area, as you know very well. And I quickly pass on these notions known all of you of one Ford are located in infratentorial with a predilection in the brainstem. The pons represent elective location, as is shown on this slide. Most of brainstem cavernoma are located in the pons, usually posteriorly, hopefully near the floor of the Ford ventricle and easily more accessible to surgery. Clinical findings of brainstem cavernoma are very heterogeneous. The beginning of symptom can be brutal with appearance of one or several associated symptoms. Sometimes the progressive clinical worsening might stimulate a tumor. These forms need usually surgical treatment. So the typical aspect in MRI is a popcorn image. You see here a hyperintense central spotted in T1 and T2 with the hypointense peripheral zone. Sometimes you can see atypical hypocenial in T1 and T2 with more mass effect and perilesional edema. Or abnormal vessel drainage is very important to know that before surgery to predict the surgical difficulties. This classification is very interesting because according to the location from subarachnoidal system, we can choose the appropriate therapeutic decision and also the best approach. We have just studied the specificity degree of radiological diagnosis, and therefore we have to estimate the risk of neurological injury due to bleeding or rebleeding of the lesion without any treatment. The therapeutic management depends on the comparison between the spontaneous evolution and the associated risk to different therapeutics. The natural history of all location of cavernomas underline the fact that the rebleeding after a first hemorrhagic episode is more frequent earlier and more important. Currently, it is well demonstrated that the hemorrhage is more frequent in deep cavernoma and the forms which is associated with venous malformations. The high rate of neurological events and the low rate of satisfactory recovery explains more the surgical attitude, especially with encouraging results on the recent cavernoma surgical series. According to this natural history, what are the therapeutic options? Surgical excision is the best treatment for cavernoma, of course, but it's still a big challenge for neurosurgeon in this location. When surgery is recommended, which surgical approach should be chosen?
We cannot hear you, Tasha.
There are various surgical according to their location. Okay.
It's okay.
You are breaking at times.
Okay. So
you are breaking at times. Yeah. Now we are hearing you very well. Carry on, please.
Okay, thank you. So sorry because I'm in the hospital and I am my connection is not good, so I am sharing my the connection by mobile, and sometimes I receive some calls. So I will put it on silence. Okay, there are various axes of brainstem surgical approaches according to the location, as I said. The median suboccipital approach, the retrosigmoidal approach, and thirdly, the subtemporal transtentorial approach, which leads to the anterolateral side of mesencephalon and the pons. Then at last, the supracerebral infratentorial approach, which is rarely used for posterior mesencephalon. And I have chosen to illustrate these different approaches by some cases from our series. First, I will show you some cases which focuses mainly on suboccipital approach, and secondly on the retrosigmoidal approach. The first patient is chosen for his particular symptoms revealed by a tumor syndrome. It concerns a 32 years old young man who presented 6 months before his hospitalization, headache, diplopia, walking trouble, and swallowing disorder. I would like to tell you a funny but real story concerning this first patient. When I told him about the risk of the surgery in this particular location, he ran away 3 times from the operating room. And each time he would find himself in the operating room, he would run back to his place bed. The only time we were able to operate him was when we dragged him in his bed and dragged him to the operating theater. So this is the initial MRI showing a big cavernoma with the mass effect on the fourth ventricle. Surgery performed in the sitting position has enabled to the complete resection of the cavernoma. Here are some photos of per operative view, the bed of cavernoma, because at that time my recording was failed, and we didn't be able to record the operation. And this is the evolution was favorable with a gradual regression of symptom. MRI control shows a complete resection and the recovery of course of diplopia. The second case illustrates the other clinical form, which is hemorrhage syndrome. It concerns a 54 years old woman hospitalized in emergency for sudden onset of agitation state, diplopia, and walking trouble. Initial MRI shows a pontine hematoma, as you see here. And the patient underwent an MRI 1 month after the bleeding, which shows a nodular lesion, because we wait 1 month because we have some bleeding with the cavernoma, and what we were not sure that it's cavernoma, not just bleeding with another etiology. So the surgery performed 1 month later because the risk of rebleeding lead to the complete removal of the cavernoma, and the patient received 2 control MRI here. You see here and here and here, and one at 6 months and the other on 16 months from the operation would have objectivied a total removal of cavernoma and with a good recovery. On this slide, the first 2 images illustrate the MRI image of voluminous bleeding here, and in the pontine cavernoma of young 17 years old teenagers who had a dramatic symptom which obliged us to operate in emergency. We performed total removal of cavernoma and evacuation of hematoma. Here are C post-operative MRI control with total cleaning of the lesion. The patient had good evolution after 6 months of rehabilitation. And in this case, you see the other location of medulla-oblonga cavernoma, which was reached by the suboccipital approach. The MRI before surgery shows a typical image of cavernoma. The second one is a per-operative picture showing a superficial location. And the last 3 are post-operative MRI showing total removal of this lesion. And here you see, of course, the fourth ventricle and the medulla oblonga, and you see here the cavernoma, and we start to remove it, and we remove it totally in the block because it was a small cavernoma. Here you see anterolateral cavernomas of the pons. MRI before surgery revealing the lateral localization in the pons. The only possible approach in this is the retrosigmoid, which we perform. This film shows the retrosigmoid approach with the park bench position. The evolution was favorable with total recuperation, and you see here, of course, when we finish the operation with the removal all the cavernoma, but piece by piece, because it was a big size cavernoma, and the total removal as the lesion is shown on this control MRI here. So in this slide there are 2 cases. It's very interesting cases because where only a subtemporal approach can be used. And we know very well now the entry zone safety entry. It's very important to know, to have a good knowledge of anatomic, of course, of this region. And here we use a subtemporal approach, case views. And the first one is MRI showing small mesencephalic cavernoma, almost clinically asymptomatic. And 5 years after, sudden clinical worsening with contralateral neurological deficit took place. The following MRI image revealed bleeding of cavernoma, imposing emergency surgery. The question is, should we operate this patient before bleeding, knowing that he was almost asymptomatic? To make this decision is very, very difficult. And the second case you see here is an intraaxial mesencephalic cavernoma. MRI is shown and an heterogeneous aspect of the central sinus with a hyposinal ring. The sequence without gadolinium enhancement showing hyperintense sinus. And the lesion related to recent hemorrhage. The sequence with gadolinium showing linear contact contrasts enhancement in the middle part of the lesion, suggesting an associated venous developmental abnormality. When we explain the risk of surgery to the patient, refused operation, and we have 2 years follow with a stable neurological status. Surgical technique has some imperative, of course. First, the incision has to be along the axis of mesencephalic, and knowledge of anatomical anatomy is very important. The safety entry zone is crucial. First, evacuation of the hematoma, removal of. Sorry, there's some problem with connection. You hear me?
Yes. Yes, we can hear you.
Of the lesion with the fragmentation without trying to dissect the periphery to remove it on one mass. Respect of associated small malformation in the peripheral area of cavernoma. Some publication mentioned that it should be to achieve radical excision involve the removal of the perilegional gliosis may sometimes contain satellite expansion of cavernoma. In my opinion, is very dangerous and not necessary to perform that in this high functional area. So there is no recommendation for timing of surgery leading with the conscientious trouble. It seems that it depends on the habit of surgeon more than on scientific data. In fact, we are often surprised by the delay between the moment of diagnosis and of symptomatic lesion and their surgical treatment. The time of reflection of neurosurgeon and the patients concerning this critical area is very deciding. And the surgical indication depends on the symptomatic characters of cavernoma. There is the histogram of this of the treatment.
1 minute.
No surgery when
1 minute, please.
Okay, no surgery when there are no symptoms, but when there is a stable neurosurgical deficit, it relies on a Karnofsky score. I think I'm in the last slides. The literature results are very encouraging. We met Professor Bertalanffy many times during many meetings. He was more optimistic about the latest result of this of his series. Here are some data emerging from some articles. And in conclusion, the brainstem cavernoma is a serious affection with a natural history, which exposed to major neurological sequelae. The selection of candidates for surgical treatment is as important as the surgical technique itself, whose recent advanced better knowledge of surgical approaches, neuronavigation, microsurgery helped to reduce morbidity. And the decision to intervene surgically in the brainstem is difficult in daily practice. Surgery should be reserved for form of progressive ornstein deficit and hemorrhagic form. It means aim should be complete resection of the lesion. Please let me share with you our next World Congress in Colombia. I hope that you can join us in March in Bogota. The organizing committee assure us that we will have a very wonderful and very important Congress. Thank you so much for your attention.
Thank you.
Thank you very much, Najia.
Right, Shireen? Yeah.
Excellent presentation. We enjoyed it. Congratulations.
Thank you, Kazed.
That's fine. I don't think we have time for more questions.
We have. Oh, excuse me. Sorry, Kasadi. Go ahead, please.
Do we have time for some more questions?
I think we are short of time, and we have 7 speakers to come for the second session. So we request that all the attendees, young neurosurgeon colleagues, to put their questions on the chat, and the speakers will answer their questions accordingly. For such an event, it's very difficult to accommodate a lot of questions unless there is one burning question that could not be deferred. But I doubt everything is possible to be answered on chat and at some other time. I'd like to thank the moderators, my colleague and friend Kasadi and Victor, for running these sessions. And I think we'll just jump to the next session. I'll ask also thanks all the panelists for having the time. Professor Najia, happy National Day for tomorrow. Regards to your colleague and to the nation of Morocco. And we move to the next sessions on endoscopy and pituitary. And I think the moderator will be Professor Ramesh Nair from England and Professor Mattias Baldoccini from Argentina. They will moderate this session. Ramesh and Mattias.
Thanks, thanks, Imad. Okay. It's been a wonderful session so far. So many questions for myself as well I want to ask, but I'll keep it in my mind. I will start with the next session. It's my great pleasure and actually honor to call my friend Andre, Professor of Neurosurgery from Netherlands. Andre, would you mind sharing your screen?
Start sharing my screen. Should be. Do you see it?
We can see the whole slides. You can go on to the slide mode.
I go to presentation mode. You see this? Perfect. Yeah, well, perfect. Thank you, Ramesh, for starting the session, and Imad and Vladimir, thanking for organizing this wonderful 3 days. I mean, 3 days of beautiful lectures. So my topic is practical and functional anatomy of going through the nose to the sella and its immediate surroundings, so mainly pituitary. I have no disclosures and no conflict of interest for this topic. And of course, we are honoring Francesco. Franco, this was during my presidency of the ENS. He was invited to Athens in 2016, just after he was elected as the president of the World Federation. So we worked together really well, and it's wonderful to see what he had achieved during his term. So first of all, often I had the question, why would we want to use an endoscope when we go through the nose? Because it is very easy for neurosurgeons. You incise the mucosa, you place a speculum, you break out everything in front and then part of the vomer and open the sphenoid sinus. And there we are at the sella. That seems very easy and straightforward. But over the years, and now it is actually 3 decades already of an endoscopic approach to that area, we know that it is about the improved illumination. We have the light really in front of us, and we see much more. It is not restricted by speculum. We have a wide field of view. And therefore, because we are not restricted by speculum, we can more easily move our instruments around. And at the end, and I think that's always important, For the patient, it means it's a reduced surgical trauma. I know that my patients were happy that they hardly ever needed a nasal tamponade for days after that surgery. Certainly in the beginning, but even nowadays, there is always a discussion about going through one nostril would be less invasive than using both nostrils. From the beginning, I adopted the binostril approach, but and that I think that's a really minor issue here in this case. So I'm not talking about the 3- and 4-hand approach through the extended skull base. This is now more anatomical, so practical, how you go through the nose and how you reach that area from a neurosurgical standpoint. The instruments, there are several available. It's very good if you have an irrigation system in it. So either ClearVision or the MineUp system, doesn't matter. Irrigation is essential in this. So when I come to the anatomy, we start in the very beginning of the nose, the anterior part of it, and the so-called middle part is the sphenoid sinus. There is a posterior part that I will not discuss, and anything going down to the clivus, that's not the issue here in this talk. If we look to the nose, and I mean as humans, we know it all, and as doctors, we know it, and as neurosurgeons, we probably don't even realize it that well. We want to be in the sphenoid sinus to see the sella, which is our goal to go through. But we have to realize that that nose has two functions. It is a respiratory organ, and it is the place where we have the olfaction, the smelling. But more than that, this whole anatomy inside the nose is made to humidify the air that we breathe in. And it helps it's constructed to remove and first maybe even trap any kind of particles and pathogens to get out of it again. And it drains any area that is collecting mucus from the sinuses and from the lacrimal duct when we have tears in our eyes. So clean our eyes. And of course, and that's a very essential sensory function, and that is the smell. Only if you lose the smell, you realize how important this function is in daily life. If we simply looked at it, most of the part of the nose that we go through during surgery is the respiratory area. But that is important. Only the upper part. We have to realize the upper part is the area where we will smell. So don't go too far up with if it is not necessary to do so. If we look to the nasal cavity, it's rather easy to realize that we have a medial wall. That's the septal area that separates the left and right side. And most of it is part of the ethmoid bone, but there is a large part of it, which is the more bony part of it. It's the vomer. And from the ethmoid bone, it is the perpendicular plate. And in the lateral walls, we see the turbinates. We have 3 turbinates, and they are there for a reason. They are there to increase the area of the nose that is capable of humidifying the air, of trapping air, of making sure that the air that we breathe in is going in a proper way, actually in a turbulent way, into it. It stays longer because of the turbinates. I come to that. The ethmoid bone is something where neurosurgeons, and I speak for myself, initially I struggled with those structures. The way through the meatus is much easier, but the ethmoids are important. The ethmoid bone is an essential part inside. We know it from the intracranial part only by the crista galli, and the cribriform plate. Think of olfactory meningiomas. That's the area. What's the crista galli? Well, we know the falx is attached to it. That's where it's there for an anatomical point where the falx will attach to the skull base. And it is in anatomical side, it is called the ethmoidal labyrinth. Yeah, well, yes, certainly for neurosurgeons, it's a labyrinth. We have an anterior, posterior ethmoid. These are very variable cells, air cells, and the inside part of that, starting with the bulla and with the uncinate process, and all, that's something we don't feel comfortable with as neurosurgeons. But to be honest, it is not that hard at all, because they are put to one side. But we should know the anatomy, because very often for the function of the nose, and I speak now about the function, you could better go through the ethmoid than removing one of the turbinates. That is something you should remember. Anatomically, the way through the nose is through the so-called meatus, superior, middle, and inferior meatus. Well, they are very simple. They are the areas lateral from the so-called superior, middle, and inferior turbinates. That's the way, actually, that's the way how the nose and the sinuses drain. So that's not so essential for us maybe, but for the function of the nose, that's essential. And we have to know that in the lateral side that we looked at, below the start where the bulla ethmoidalis is, we have the semilunar hiatus. And there the sinus, the frontal sinus, maxillary sinus, is draining. So you don't tamper with that, because otherwise the patient will have a chronic sinusitis. You should be, at the end of a neurosurgical procedure, you should clear that area. You should just check it, just a few seconds with your endoscope, that the semilunar hiatus is open. We just have to think that's a very small part of it, but we do that because of the function of the nose. We hardly ever tamper with the opening of the nasolacrimal duct, because that is below the inferior turbinate, and that's the turbinate we as neurosurgeons usually, when we go through the nose, don't tamper with at all. If we look to the airflow through the nose, if you sniff very slowly, it is still a kind of laminar flow, but usually breathing in, because of the turbinates, will cause a turbulent flow. And there is a reason for that. First of all, it stays longer inside the nose, so the air is humidified, and it brings the air to the upper part so that we can smell. If you remove turbinates, even if the olfaction area is still intact, the air will not reach the upper part and the patient will not smell. So you can say, I didn't tamper with the olfactory mucosa or with the nerve. But if you tamper with the turbulent flow that is done by the turbinates, and that's essential for our function, then the patient has a deficit afterwards in nasal function. Looking to vascular supply, I mean, vasculature is important. We know that for all the talks and for neurosurgeons, we have the posterior and anterior ethmoidal arteries in the roof of the nose. Those is for the straightforward way to the pituitary, to the sella, we will not see a lot. But the septum is, of course, fully supplied by that. And we have the greater palatine artery coming from below through the palatine. And the most important artery for us, because it is closely related to the ostium of the sphenoid sinus is the sphenopalatine artery. It's in the base of the middle turbinate, where the basal part of the middle turbinate attaches is the ostium, the opening, the foramen of the sphenopalatine artery. We just have to realize that. And if you think about the nasoseptal flap, you have to realize where that artery is to maintain the function of that flap. But also think, not especially the anterior, but mostly the posterior ethmoidal artery. Don't tamper with that if you want to have a vital flap. Innervation, we know the nasociliary nerve in the front, but the nasopalatine nerve. But here, this picture shows that we know the olfactory nerve, but it's actually the bulb. The nerves are all those little nerves going through the sieve of the cribriform plate. And they extend quite far down. So just quickly and easily coagulating all that area will tamper with the smell function. So don't do that. If we now look how we go with an endoscope through this whole area, you see the ethmoidal bone in pink, and here the inferior concha, the turbinate, we hardly ever mention that. But we go below the middle turbinate. That's the way you go with an endoscope. So you move your endoscope, which is a rounded oval structure, below the turbinate. And then at the very end, when you see the choana in the pharynx, you slowly move up because the ostium of the sphenoid sinus is in the upper part of it. The ostium is always there, don't worry. Sometimes it is not visible. There is some mucosa over it, but there is always an ostium. 100% sure there is an ostium. So if we look to this again on the left side, inferior turbinate, middle turbinate, if we go there, we see the choana with our endoscope, and this is the base here in the lower part, it's the base of the middle turbinate. And when we then move up, you see that ostium. That's the ostium. But to open it, we have to go down. We don't need to go higher up, because if you then here in this part already of the septum, there is olfaction. That's olfactory function. Now look to the middle part. So when we finally, that's a neurosurgical part, I always call it. The anterior part is ENT, the middle part is neurosurgeon, but you have to know all of it. Even if you have an ENT colleague doing that approach for you, you should know where it all is. You should be capable of doing this yourself too. So in the middle part, we see the sphenoid sinus. You open that ostium and we have something that we feel more comfortable with. And actually, usually ENT surgeons are more uncomfortable by seeing such structures like the optic nerves on both sides here, the optic carotid recess. And I mean, this feels more at home. These are the structures that are known to us, and that's essential. So this is something we see these recesses on both sides. Sometimes and we call it the so-called bulldog sphenoid sinus, where the larger part of the nose of the bulldog is the enlarged sella. But sometimes you have, especially in the Cushing cases, you have smaller cellas. Then you more easily see, because the cella is smaller, you see both recesses, optical carotid recess. We call that the little seal type of cella, which is, but it's always think of the two eyes and the nose in between to realize where the structures are. Then we have some bony structures inside the sphenoid sinus, and those structures are our landmarks. Many of them, they are variable, very variable, but you should study them because many of those lateral parts of the septae, they go to the carotid arteries. So study them. And if there is a possibility, do a high resolution CT scan. But sometimes it is not possible, you don't have it. But if you have it, it's in such a CT scan, you really see the variation, because sometimes only one side of the sphenoid sinus is aerated below the cella and the other part is not. You can see even if part of the adenoma is already breaking through the cellar floor. You see here an onodi cell, so this is still part of this. It's a posterior ethmoid, but you can open that to have a wider access into the sphenoid sinus. But you can just see that here. This is the high resolution, really thin sliced CT scan that shows all the different parts of the anatomy, especially in the sphenoid sinus, that we want to know. If you only enter in this large part, you think that's the cella, you don't find it. You have to go through all these septae. And
2 more minutes, Andrew.
Yes, I'm come to the conclusion. And here, sometimes MRI scan, you don't see it, but if you juggle a little bit with the window, you can see those structures here. You can see it also in an MRI scan, but you have to play a little bit with it. I will stop with some recommendations. I always tell the people, when you want to do endoscopic endonasal approaches, make yourself familiar with the nasal anatomy, because essentially it is not that difficult. And practice endoscopy as often as possible, also to make yourself more familiar with the equipment. Check the anatomy of the patient, individual anatomy. It is not standard anatomy, it's individual anatomy. And also be interactive with your anesthesiologist, especially when you start with a procedure. You don't want to have septals and mucosal bleedings, so check that. And personally, I think that the knowledge of functional anatomy of the nasal cavity is really essential for the end result, because you want to have a good neurosurgical result, but without adding nasal morbidity, because that can decrease the quality of life of your patients, and you don't want to have that. So thank you so much for your attention.
Thank you. Thanks, Andrea. That this anatomy can be confusing for all of us, and they beautifully described it, simplified it, and also approached on the practical applications of knowing the anatomy. We'll get time to discuss at the end, so I'll go to the next speaker, Professor Dong Wan Hei. He's going to talk on the endoscopic approach to pituitary tumors, pituitary adenomas. Do we have Prof? Okay, yeah, thank you, Prof. Dong Hei from Vietnam, and great to have you here. You can start now. Are you on?
Yeah.
Okay.
Yeah. Can you hear me?
Yes.
Okay. Good evening, everybody. And I take a moment to say many thanks to organizing committee, and I would like to say many thanks to Professor Franco Chevade, who is excellent neurosurgeon in the world, and who is very excellent mentor, and he's visited us, give lecture, help our society as my department, as other department in the world. And today I would like to share my experience in the treatment of pituitary adenoma by endoscopic endonasal trunk approach. I have more than 700 cases endoscopic for scan-based surgery, including 500 pituitary adenoma. And as Professor Andrew said, the first thing is very important for every surgeon is anatomy. we need to study to know everything about the pituitary gland and other around structure. And this is always very important for everybody. And some arteries, chiasm, ICA, and everything. The sphenoid sinus, the nasal cavity, and everything we have to learn, we have to study before. And for indication in this approach, everybody knows that it is very clearly. And the first lesson is very important for the young neurosurgeon as a beginner for endoscopic approach. We need to evaluate preoperative, like clinical evaluation, hormone evaluation, and imaging evaluation. And the CT scan is very important before surgery. With CT scan, we can know sometimes the ICA eminence, the sphenoid septum, or ICA protrusions into the sphenoid sinus. And the other side is the same thing. Sometimes they are the bone over the carotid artery is very thin. And it is, in that case, it's very, very dangerous if you don't know, if the surgeon don't know about that. And we can see the optic eminence too on CT scan. And of course, MRI is so important too. We can see the tumor, you can see our own the structure around, of course. And sometimes we can see everything like a chiasm, pituitary gland, and we can see the tumors come inside the cavernous sinus. And so for the microadenoma, it's more easier, but we have to know, especially in the young, for the young neurosurgeon, we need to know where the tumor, where is the pituitary gland. And in that case, the same things. And sometimes it is very difficult to do this approach. In that case, there are no sphenoid sinus. We can do, but very, very difficult and very, very dangerous too. Another case, the same thing. I have some case like that, and I think this is very difficult to do endoscopy for this case. And some other complicated tumor is not for the beginner. I see it again for the young. Don't do this. Don't do endoscopic approach for this tumor. Very complicated. For the procedure, there are 5 steps. The first step is take a flap, mucosa flap, and we need to study anatomy, the nasal septum, the median tubulate, the inferiors, and one time it is olfactory mucosa area. As Andre said before, we need to know where is the olfactory mucosa area, and we don't do it. We don't inside on this area. And we have to know the branch of platino artery. And how you can do the mucosa flap is not so complicated, but we need to know where you can make a superior incision, inferior incision to get a flap. And we need to identify the sphenopalatine artery too. And the second step is to remove to open the sphenoid sinus. And so for beginner, we have to identify on the anatomy, and we gently make the working channel is bigger. And I don't like to remove the midden tubulate for the small one, for the not extended EETA. And like Professor Andre said, I don't like to make more lesion on the tubulate. And I usually use the monopolar to make mucosa flap. And after that, we can expose the anteriors of the sphenoid sinus. And in that case, we use high-speed trin to remove the bone. It's not so complicated, even with the young neurosurgeon. And we, after remove, we can go inside the sphenoid sinus. I usually remove totally the mucosa of sphenoid sinus. And after that, we can use DRIN to remove the septum. The septum, and we can expose the cellar floor. And step 3, now we open the cellar floor, and we need to know everything like anatomy. This picture shows ICAs, optic, and when it is more easy now. We can use the high speed trin to remove the bone, and it's more safe. And I start to open the cellar floor with trin, and after that with correction we can make it bigger. Another case, we can see more clearly. In that case, the cellar is very thin because the tumor is go down in the sphenoid sinus. It's more easily to open the cellar floor. And now you can open the diameter, and we can, but the floor, the cellar floor, it's we have to open as big as we can. And now you can open the diameter and remove the tumor. And for remove tumor, I would like to dissect the tumor and to see the limit between the tumor and the other structure. This is pituitary adenoma hemorrhage. It's very easy to remove the tumor by dissect, and after that suction, and we can remove them by suction. And another case, and I usually use the scissor to open the diameter as big as we can, up to the both sides like a cavernous sinus. And so the tumor is soft. If we open the bone, the cellular floor is so big, it's more easy to control and more easy to remove the tumor. And sometimes we can make CSF leakage in the end when we remove totally the tumor like that. Another case in the end, you can see the arachnoid is go down in the spinous sinus. It is a good sign to confirm that there are no tumor inside. The final step is to closing. I usually, in case of very simple case, very easy. If we don't see any leakage of CSF in the end, the closing is very simple. I usually use 6G cell Zen foam, and after that, nasal mucosa flap is okay. You don't need to do more. Sometimes I need to do reconstruction of the cellular floor. Sometimes not always. In that case, we can see the cellular floor is reconstructed and the surgery cell before. And sometimes we do close the quick apolabros. To avoid the CSF leakage. And sometimes when we see, in the end, in that case, when we can see some leakage of CSF, I usually do multi-layer for closing. So then from the 6G cell, after that, fat, again 6G cell, and again fat, and so again 6G cell. And for the last one is nasal mucosa flap. And for some case, we can see the CSF leakage. Another case, for the extended approach, we can see the big opening of diameter. I usually use a multi-layer technique, the 3D cell, Zen foam, and apolabros. It is very important, these techniques. And after that, fat, 3D cell, fat, multi-layer. And fat again, 3D cell and fat again. And some case, when I see the big opening of diameter, I usually use multi-layer N plus quick And sometimes I use the balloon for compression. It is very good in case sometimes when you see the big opening of durometer. I usually use Foley catheter. It's very cheap and very easy to find in the hospital. And sometimes, if the opening is so big, I use the suture technique. I make some suture on durometer. For the beginning, it takes a long time, but nowadays take 10 minutes to make some suture, and it's very, very useful. It is very useful for stop CS application. But then some other complication for this approach. And this is one case I will show you. This is the bleeding from the sphenopalatine artery. I tried to stop bleeding with bipolar, but it didn't work. And in the end, I stopped with the monopolar. And it's something you have to study whereas to avoid make injury on this artery during opening. And another complication is more serious during opening. The cellar floor, sometimes we can make a big mistake. In that case, it's ICA injury. I have 2 cases of ICA injury. This is the second one. The first one is die because of ischemia, because of operation of ICA. But this case, I try to stop bleeding during surgery with motion. It is very, very, very serious complication, and I try to stop bleeding with motion, surgical motion, and in the end with Apollo valve and the balloon, the Foley catheter. And after surgery, I do DSA. It shows good, and the patient is good. There's no any neurological deficit. And that's why, yeah, that's why we have to prepare everything for this approach. And so, conclusions, I have 5 points for the young neurosurgeons. We need to have a good preoperative evaluation, and we try to open sphenoid sinus as big as we can, and we try to dissect the tumor for close. In case of risk of CSF leakage, we need to technique of multi-layer, suture dura, and balloon. I stopped to use bioglue. I never use bioglue from 5 years. And the last lesson is we need to prepare before surgery for ICA injury, because we never know if we can make the ICA injury during surgery. Thank you very much for everybody, and welcome to Vietnam. Thank you.
Thank you very much. Great lecture, a lot of valuable lessons, especially for who's starting out the endoscopic work. I'll go on to the next speaker, Professor Chandrasekhar Jopurjari, is well known to all of us, really a world expert on the endoscopic work. And I would ask Chandra to present at the second ETV. Chandra, all yours, Chandra. And
thanks, Ramesh, and thanks, Imad and Vlad, for this opportunity. I'm really happy to participate in this session, which is being held to felicitate Franco. I think Franco has really been a very active and has paid special attention to some of the needs, especially in trauma and hydrocephalus. And I thought I will choose one of the topics which probably has made a great impact in the developing world of what we like to call secondary ETV. Basically, endoscopic third ventriculostomy is now a well-established treatment for obstructive hydrocephalus with a success rate of over 70%. But there are now several attempts where it is being applied to communicating hydrocephalus in older children and adults with a moderate success rate. However, what is emerging is that the ETV has been very successful, almost as good as primary ETV in many cases when you do it for shunt malfunction. This is one of the patients, a 4-month-old child who came with aqueduct stenosis, was shunted outside, and the child came to us with shunt infection. Obviously, we removed the shunt. We treated this child with antibiotics, but as the original pathology was aqueduct stenosis, we thought we should go ahead and do a third ventriculostomy as the first alternative rather than going in for another shunt. And as you can see in a post-infective patient, you see some Seineke formation at the foramen of Monroe. You see some kind of a, the choroid plexus looks quite dirty, and the floor of the third ventricle also looks not as transparent, but you can see the basilar artery quite well. These are typical post-infective kind of subependymal nodules. And once you see that, one with a fair degree of certainty going closer to the dorsum sellae, you can make an opening into the third ventricular floor, and then with a balloon like a regular case. And here comes the main crux of the matter as to how much the basal cisterns are scarred. It's not too bad here. And in fact, this child was treated about 6 years ago and did not need any further treatment. I think as early as 1993, first 3 cases of ETV after a shunt malfunction were reported from Japan, and they used a flexible endoscope at that time. And I think one of the most important papers came from Necker, where Chinali has talked about 30 cases undergoing ETV for shunt malfunction with a 76% rate of shunt independence. What was also remarkable is that out of the 7 failures, 3 were technical, while most others occurred within the first 2 weeks. So if at all we are going to have a failure, we come to know fairly early. There is another paper which showed from, I think, Italy, which showed that probably it may depend on age. If you do it in children below 2 years of age, then probably you're likely to fail like the primary ETV. While in older children and adults, it is probably more successful. There is a recent paper in neurosurgery which talks about the outcomes in shunt malfunction, and they are talking about 51 out of 80 patients who became shunt independent, while 4 required repeat ETV, and there were about 29 failures. So over 60% success rate. And they also found that age has been a predictive factor in there. Now, I think what is very important is that probably the primary pathology does not matter so much, as has been shown by Professor Grotenhuis, Charlie Teo and Robert Jones earlier, and this kind of a multiple center study which showed that you get much better results in some pathologies like post-hemorrhagic and post-infective hydrocephalus if ETV is performed after shunt malfunction rather than doing upfront during the primary disease. And this is one such patient who came with tubercular meningitis, hydrocephalus, shunt put in childhood, and the child came back, the boy came back in teenage, and he now has a shunt malfunction. And obviously here, though the pathology was tubercular meningitis, the fourth ventricle wasn't so large, and we thought that we should give it a try. And again, you find that there is a dirty looking third ventricular floor, but the anatomical margins are fairly well seen, and you can see the basilar artery. So you can make an opening here. And once you see that the prepontine space is not very badly scarred, you become quite confident that you are more likely to give a good outcome in these kind of patients, as you will see in a short while. And this patient has not come back almost 9 years now. Schroeder showed that if it is an obstructive hydrocephalus to begin with, there is a better chance of success. Same statistics in 28 children by Sufianov. But I think one of the most important papers to come out was the role of radiological anatomy. Rather than the primary pathology or the age, what matters most probably is the radiological anatomy. If you find that in a patient with shunt malfunction, the fourth ventricle is not very dilated, then you are most likely to have a successful result. This is one such patient where you see that patient is very symptomatic. Sometimes with rigid ventricles, you don't get too much ventriculomegaly in these patients. And we thought that we should try it out to do a third ventriculostomy in this patient. This kind of small pieces of brain come out if you do not have a transparent sheath, which we did not have at that time. We used to use it without trocar, and then again opalescent membrane, but you get a good prepontine space, and it has worked quite well again about 6 years after the patient has had. So a patient who's chronically shunted for almost 11 years, you can still safely do a third ventriculostomy, and it has worked well. And we have summarized our experience of 44 cases in this paper in pediatric neurosurgery, where we have shown that in shunt malfunction as well as previous ETV failures, we have been able to do it in post-infective cases, 15, blockage of shunts, 13, non-absorption of CSF from peritoneum, 8, and shunt migration, 1. And one patient of silicone allergy is quite a remarkable story. And we found that there was almost 70% success rate in secondary ETV for shunt malfunction and 75% in ETV failure patients. This is a patient with silicone allergy, had almost 3 shunts hanging from various parts of his trunk because they were getting extruded. He already had about 16 surgeries so far. And it was not realized that this was his major issue. And in spite of the fact that we could locate the third ventricular floor only with navigation, we could manage to make a good opening here. And you can see a good CSF flow post-operatively at 3 months. And this worked quite well for over 2 years. Additional procedures in certain patients when we do a secondary third ventriculostomy may be necessary, like septostomy and aqueductoplasty. This is one such patient with tubercular meningitis. Only unilateral ventricular drainage and septostomy in this patient solved the problem, as you can see here. In a spina bifida, when the foramen of Monro is not so well dilated, we have occasionally done septostomy, tried to go from the opposite side, which became, we have gone through the naturally occurring septostomy, a third ventricular floor, and here again, we could do a successful third ventriculostomy after we have done a septostomy in such a patient. I think in spinal dysraphism and probably some post-infective, post-hemorrhagic cases, probably the secondary third ventriculostomy works better than primary third ventriculostomy because CSF absorption improves over a period of time. This is another patient where we did this endoscopic third ventriculostomy after a shunt failure. And what we found is that once we have done a third ventriculostomy here, we see that the prepontine space actually is badly scarred. There are dense adhesions here. And then we turned our attention to the aqueduct, which had a membranous kind of aqueduct stenosis. And membranous aqueduct stenosis is one indication where we are happy to do an aqueductoplasty, get into the fourth ventricle, and this child has had a good outcome after this procedure. Another patient where we do an aqueductoplasty occasionally is a patient where we are doing a re-ETV or a shunt failure. And again, if there is a membranous kind of aqueduct stenosis, occasionally we will also do this when the fourth ventricle is abnormally large, because sometimes you can get a good outflow. Stenting or not is a controversial issue, but we do not use any stents. This is one such patient where it worked. We kept a tube in the fourth ventricle, and later on, I think about 6 months later, we had to probably connect it to a shunt, if I remember correctly. But this worked quite well for over 6 months. In multiloculated hydrocephalus with septostomy and with opening of the various sort of septae, in the multiloculated case with the use of ultrasound as well as navigation, you can make this kind of a unified kind of a hydrocephalus, and then you can do a third ventriculostomy. But as we discussed earlier, I think the main problem comes is when we have done this, you find another kind of a scarring in the prepontine space, which may not allow it to function so very well. We usually, in such patients, try to see if the CSF is flowing properly by doing a dye study, and in this patient, it worked quite well. But a year later, this patient required a shunt. So there have been several communications now which talk about several aspects of secondary third ventriculostomy. Which patient has more chances of getting rid of the shunt? And it appears that many patients with shunt malfunction can benefit. Age at secondary ETV, number of previous shunt revisions, and ETV success score can help in identifying these patients. And there is a paper which shows that if you ligate the shunt at the same time or remove the shunt at the same time, you are more likely to succeed. And this is what we have done whenever we have been quite sure about it or converted it into a reservoir and then taken it out at a later stage. So I will sum up by saying that ETV, whenever possible, may be first used in shunt malfunction at any age or any etiology. Ventricular anatomy gives a very good indication of feasibility and chances of success. Fenestration of septae, adhesions, foraminoplasty, aqueductoplasty may be added as necessary during this secondary ETV, and it may simplify hydrocephalus in multiloculated or complex hydrocephalus. Thanks for a patient listening.
Thank you, Professor Dev Pujari. That's been an excellent talk. Vast experience with all these complex cases. I think we have a similar talk coming up by Prof. Asmi Elias. I don't see Matthias here, so I'll ask Prof. Asmi Elias to start showing his slides. Asmi?
Thank you very much, Ramesh, for your kind introduction. Special thanks to Professor Imad Kanaan, as well as Vladimir Benes for the invitation to honor our past president of World Federation, Professor Franco Sevade. So I decided to choose this topic, which is very close to my work. I have special interest in endoscopy and pediatric. So my talk will be on endoscopic treatment in complex infective hydrocephalus. So infective hydrocephalus occur as a result of infection in the brain. It can be acute or chronic. It's could be rare in a developed country, but it's relatively common in developing country. And it can be reported as high as 30%. There are various causative organisms depending on the age of the child. In neonates, commonly secondary to gram-negative E. coli, or could be a strep B meningitis. Whereas in preterm infant till 3 months, their commonest organism are usually Staphylococcus and Haemophilus influenza. The neonate usually they can have infection to intrauterine through cross-maternal infection, but sometimes they can acquire infection in the early part of their life, not recognized, and eventually develop meningitis.
This is one example of a prematurity who developed infective hydrocephalus complicated by pyogenic ventriculitis, severe form of infection. Even though aggressive treatment was done, craniotomy, evacuation, but eventually the child succumbed to death. Infective hydrocephalus also can happen in a children who was born with hydrocephalus, for example, with myelomeningocele, in this case, achondroplasia, VP Shandan, but shan get infection. So after shan infection, as you can see, it causes secondary infection to the abdomen. It can cause peritonitis, and all this is a nightmare to any neurosurgeon in managing infective hydrocephalus. So the pathophysiology in infective hydrocephalus, there will be increased cellularity associated with fibrotic adhesion and septation that form on the arachnoid secondary to the inflammatory process of the offending organism. The vessel become congested, resulting in exudative material, especially in the vessel system and the ventricular system. The leukocyte and plasma cell migration into the CSF make the CSF become congested and turbid. Pus formation eventually covered the arachnoid correct plexus, and this eventually will lead to impedance of the CSF circulation and resorption, and eventually result in hydrocephalus. So the reason that I show this because in early years in 2008, we conducted our cross-sectional study in our local series looking at the 12-month survival of shan, which is the commonest procedure. But unfortunately, we found that only 60% of our shan series in children less than 12 years old survive. And we have a very high complication rate, 41% develop complication within 12 months, and we have a 23% with the infected shan. So one of the problem that we faced at that particular time was pyogenic ventriculitis. This is a very rare complication of severe intracranial infection, a very high potential life-threatening. Even in our series, majority are gram-positive and gram-negative, and the mortality can goes up to 70%. So we had a problem. Traditionally, we put an EVD and we change the EVD every 3 weeks, and then we give antibiotic, and most of the child died because of the severe ventriculitis. So we decided to change our approach. We need some more aggressive treatment. Therefore, we introduced endoscope. So pyogenic ventriculitis, the child usually presented with high-grade fever and sepsis, meningism. They have poor oral intake and typical obstructive hydrocephalus, and you can see inflammatory exudate. This is a typical CT scan that usually we do with a typical ependymal enhancement, and you can see the sediment gravitate down in the occipital horn of both lateral ventricle. And this is a very typical feature of CT scan, and of course supported by radiological, clinical, as well as hematology to suggest a severe infection. So 6-month boy, premature IVH, hydrocephalus, VP Shandan, infected by Staphylococcus aureus, as you can see here, external infection. But in fact, the child come in septic state, and this is a CT scan showing that sediment in the ventricle. So what we did, we decided to put in endoscope to see what's going on, and at the same time, we try to clear the ventricular debris as much as possible. So in the early phase, we use a Minop from Ascolab. It's a blunt tip for working channel. And we use infant feeding catheter, which is transparent and with a blue tag on one side. And we cut it proximal to the distal opening, as you can see here. So, okay, unfortunately, the video doesn't work. All right, I will show another video later. This is what happened pre-operative and post-operatively. You can see the debris can be removed effectively using the lavage technique. So this is 1 week after lavage and 3 months upon follow-up. So in the initial phase that we only do one side, but we found that we also do septum pellucidotomy. So, but later we found that there is a hidden pocket, because as you put your endoscope, you can only work along the line of the scope. Yeah, there will be a hidden pocket when they attempt to remove the slough. In the hidden pocket, you may damage the part of the ventricle. So from then, we decided to do bilateral endoscopic lavage for all pyogenic ventriculitis, which have a better results. So this is just to show you the difference between unilateral and bilateral. And we use an infant feeding catheter. We cut straight. So this is actually underwater surgery. When you do the irrigation, you must make sure that the water irrigation get into the pocket. Otherwise, if it is wet, the dressing, so the child may develop hypothermia. So we connect our system into 3 ways, stopper like here. We connect to 20 cc syringe. So this is the early experience. This is about 14 years ago. We review about the first 8 cases, a majority caused by Staphylococcus and some gram-negative E. coli, Serratia and Klebsiella. So by doing lavage, majority, actually all 8 patients survived, no complication related to the procedure, and all of them required additional antibiotic about 6 to 8 weeks. Only 4 required VP shunt. So ventricular lavage was quite common in our hospital. Even nowadays, we still do it only for pyogenic ventriculitis and very selective ventriculitis in children. So this is just to show you that we connect the catheter to the suction. So by using a control suction, you can aspirate the slough accordingly. And you can see this is a mistake because we did not put proper draping, non-resorbable, so that causes wetting of the dressing that can cause hypothermia. This is one of the critical steps when you do lavage, especially in young children. So the advantage of endoscopic intraventricular lavage is offer a minimal access technique in removing the ventricular debris and pass under endoscopic visualization. You can have a direct assessment of the ventricle, immediately clear the CSF. You replace the CSF with artificial solution. In our case, we use Hartmann. You also minimize the risk of future adhesion, septation, and by improving the content of the CSF, you can also prevent debris and blockage. So there are various techniques that we advocate. We use a feeding gravity feed, in which we hang the Hartmann solution warm to body temperature for the children, and we put on the drip stand. We also connect the 3-way catheter with a shrink 20 cc on certain part of the procedure. We give a positive syringing in order to clear the slough, especially the view from the endoscope. And we also use some other technique that we describe as sweeping and grasping, which I'll show you shortly. So this is an example of the slough. As you can see, usually we do not start the irrigation first. We go in, and then once we find the big area of the slough, we use an infant feeding catheter to aspirate it. As you can see, there are certain techniques that we do not simply go to foramen Monro. Usually we attack from the upper half of the ventricle, from top, and everything moving towards the foramen Monro. Half first and followed by below towards the Monro. And initially, you will see everything slough. But once you get some clearance, you try to get to the normal ventricle wall as early as possible, and then you move towards the slough. So using this infant feeding catheter, which is a little bit flexible, you can see you can sweep it, but you have to be very careful, especially when you work along the core plexus, because it can stimulate hemorrhage. But if a small bleed, usually it can get controlled easily using irrigation. And we can use also the tip of the Minop endoscope because it's round. As you can see, actually we elevate the carpet, or we call it a carpet of slough, and subsequently we can irrigate using a flushing technique as well as a grasping technique. So, but be careful, we do not do this technique in acute phase because the ependymal can be very friable. So that can result in severe hemorrhage. So you have to optimize the patient first. Usually we temporarily put an EVD, give antibiotic, build up the child. Usually we wait for a couple of days, even 1 week. We get a very good CT scan showing that big ventricle, ependymal enhancement, then only we do this technique. Because if you do it in acute space, especially when the ventricle are not dilated, you can cause a lot of trauma, especially with the endoscope. So you move from the normal ependymal lining until towards the slough. We do the lateral ventricle first towards Monro and third ventricle. Then we do on the opposite side, and eventually both sides join in the third ventricle. You can imagine that if you just put an EVD, there's no way that this slough can be removed. You need to be aggressive, mechanically remove by using an endoscope technique. This is a keyhole approach. We do not use intrathecal or intraventricular antibiotic because it could have some reaction to the ependyma, but we rather use systemic antibiotic and mechanically remove it. So initial treatment we use for pyogenic ventriculitis. As we move along, we expand our indication, especially for those who have previous infection and we have a recurrent shunt infection or recurrent shunt malfunction, because we know that patient with previous hemorrhage or infection, they have a lot of debris that can cause a blockage of the ventricular system or the VP shunt. So by doing a lavage, you can clear it and you can make the shunt survival better. We also use for those with high cell protein count with recurrent shunt malfunction, and we also use for IVH both in adult and pediatric, and sometimes adjunct procedure for tumor of post-clipping aneurysm. This is a 2-year-old congenital hydrocephalus, VP shunt done, but for some reason the child had repeated shunt malfunction. The family not so happy, so they want a ETV instead of shunt. So we say very difficult to decide. So we go in with the endoscope, as you can see here. As you enter, it's a very high proteinaceous, a lot of oily kind of thing. This indicate by a lot of debris that cause the shunt malfunction. Okay, as you enter the third ventricle, this is actually aqueduct. The aqueduct is open, and then we move forward. This is actually a previous ETV was attempted in another hospital, but you can see here in children, especially post-infection as well as post IVH, they will tend to heal. When they heal, they form a very thick scar. Yeah. So sometimes attempt for secondary ETV may be very difficult, but in this case, we have to a little bit use some force. But unfortunately, the preponderant space fill up with many addition. So we fail to do a re-ETV, even though we make a stoma, we temporarily put a EVD and we clamp it, but it doesn't work. So we have to convert to VP shunt. But with lavage, the patient have no more required any more revision of shunt, because we have done lavage, we have cleared the content of the CSF that make the shunt survival very much better. So sometimes you can have a simple, infection like this, previous shunt, and following healing, you can see there is a monoventricular hydrocephalus. Definitely, the obstruction at the ipsilateral foramen of Monro. This is the effect of healing. It seal off the ventricle. So we do endoscopic, lavage, clear the content, and subsequently we release the addition, and we do not need any revision of shunt, because by releasing this, we pull it out, and then the shunt function back again. This is another case. This is immediate post-op. Another case of another monoventricular hydrocephalus. You can see following infection, the Monro blocked by this slab. Yeah, it's a bit friable. We just do lavage. We try to remove only part of it because we don't want to cause damage to the fornix. And subsequently, this patient had previous VP shunt, and we do septum pellucidotomy. So this will connect the ipsilateral ventricle to the opposite side. And once you see this, usually you have to lavage, make sure that it's clear on the one side of the ventricle before you contaminate to the clean part. So this is the other part. You can see the ventricle catheter is nicely sitting there. So this replaces the foramen of Monro. In other words, the CSF will be diverted through this multiple hole that we created to the septum pellucidum. Sometimes you can have multiple septa because of a healing process in previous infection. Compartmentalized hydrocephalus, previous years you do multiple shunt or multiple connector. But with endoscope, you can use a multiple fenestration. At the same time, you can convert into only one shunt. Okay, the idea of endoscopy in compartmentalized hydrocephalus, you can have a diagnostic, you can fenestrate the septa, you can establish communication between all the compartments, you can release the addition, clearing the debris, and replace with the CSF. This is quite easy, straightforward, but sometimes you can have a compartmentalized hydrocephalus with previous infection. This is typically quite common, especially we have previous shunt, and then you can see the shunt is located at the area of the choroid plexus. So in this particular case, you have to look at the tip of the shunt in the perpendicular 90-degree. So we go in, we decided to go from the left side so that I can see the tip of the ventricle, so I can clear it from the addition. And I also do septum pilocydotomy to communicate.
We lost Prof. Alias. Yeah, I think we've lost him, maybe related to the internet connectivity there.
Yes, we lost him.
It looks like he was toward the end of his presentation.
He was coming to the end, actually finishing his
Yeah,
time in
so
another
I
4 or 5
think
minutes.
we just move to the next.
Yeah. Okay. Well, Matthias, I think you could probably start, and we can ask Asmias later on if he wants to talk on something.
Of course, Mahmoud is here. Mahmoud is connected.
Moody?
Yeah, thank you very much. Let me just get my screen. I think we're still...
Good morning, Professor Mahmoud. Mahmoud Qureshi, neurosurgeon and a close friend from Nairobi, Kenya. This is the next
share
topic.
my screen for some reason.
The next topic is small step towards the bigger picture with minimal access approaches. Thank you very much.
I can't seem to be able to see my screen to share. Okay. Yeah. You able to see my screen now?
Yeah.
Yes.
Sorry, I'll just go back. All right. You may be wondering what the topic is all about. It essentially is a tribute to Franco. Franco, ever since he came, has impressed us with his humility, and by not making very huge bangs about what he does, he's been very effective by taking small steps all across the globe and making a huge impact. And that's what I felt with the minimal access discussions that I want to just show briefly, that how it matches the personality of Franco. And really, I've been almost humbled and privileged to work with Franco over the 4 years that I have been able to see him. And I feel that this really is a gratitude to the moral conscience that he has held for the WFNS. It's been a real privilege, and I know that all who have worked with him will concur. So what has Franco's contribution, as far as I have seen from Africa? He's contributed to truly the continent rising. How has he done that? He's done that by his role through his research activities, where he's constantly at every lecture been showing and highlighting the plight of LMICs through the trauma burden that he really has become a master at demonstrating at every conference. And really, he's upped the ante in the way trauma is seen in our region, in our LMIC regions. And really, before, people were not as cognizant of the impact of trauma globally, but he's highlighted time and again through his conferences and his presentations that really the burden of trauma is much more than where a lot of the funding has been going. So, and essentially, he's been demonstrating a deep passion for the development of neurosurgery in LMIC countries. Ramesh, Imad, and Vlad will know this theater when they came to Nyeri to work with Andrew in that small theater. And he's been supporting the development of new sites all across the globe. And this is an example of one that in Mombasa, where we had a hugely successful conference, from the mission hospitals in the foothills of Mount Kenya to enabling a galaxy of neurosurgical leaders to come to us in LMIC countries and develop our new sites. So really a man with a deep passion for LMIC, through his small steps, as I said, continues to make a big impact, encouraging and supporting the young neurosurgeons all across the globe. This is an example where one young neurosurgeon started in the coastal province of Kenya, and he was out there with his team, who are seen here, Vlad, Ramesh, Salman, and many others who essentially were out there to support us. From the from the hills of Mount Kenya to the desert lands in North Africa, Franco was always there. He's always been very, very supportive. He's been working hand in hand with the global and continental leadership in order, through his small steps, making a big difference all across the globe. So, being that this is a neuroanatomy talk, I'll just highlight the value of small steps through minimal invasive procedures with the use of neuroanatomy in arriving at an appropriate treatment. This is a demonstration of a child who essentially came to, let me just move this a little bit. So this shows a child who has a large cyst and was diagnosed to have a cisterna magna. And the dilemma for the treating surgeon at that time was whether to shunt or not to shunt. They opted not to shunt, and then unfortunately went into problems. The shunt got complicated. There was a bowel perforation with the distal catheter extruding via the anus. The distal catheter was replaced by the original surgical team. The proximal catheter was left in situ. Not surprisingly, meningitis developed, ventriculitis happened, and Azmi has shown us how he very effectively treats this. And these were treated with intravenous antibiotics, with the VP shunt left inside, the ventricular catheter left in situ, and a second proximal suboccipital catheter was placed into what they thought was a Denti-Walker cyst. And there was a short-lived clinical improvement followed by a gradual deterioration. And there was then referred to us for consideration of an endoscopic third ventriculostomy. But in a situation like that, it can be pretty dicey to do a third ventriculostomy because it wasn't a cisterna magna. It was actually an arachnoid cyst that had pushed the third ventricle across, had pushed the aqueduct. The third ventricle was displaced, as was the dilatation of the third lateral ventricles, and we had the cerebellum just pushed down. So here is a dilemma of management. Do we do an ETV? And if we do, are we going to get into difficulties with the well-known circle of unhappiness? So we decided not. Looking at the scans, you could see the reason why things had been gotten into trouble. There was the just a small tip of the VP shunt or ventricular catheter seen. Ideally, it should have been in that position. So we decided that this was an appropriate case for a suboccipital supracerebellar approach for a microsurgical arachnoid cyst fenestration. And the reason for that was that if we could get in there under the trochlea, get into the arachnoid cyst and then open up the cyst and actually visualize microsurgically the third ventricle and open it for an effective entry into the third ventricle, we were likely to be more successful. So this is just a demonstration of what we saw when we entered into the arachnoid cyst and then opened it up, and then the egress of CSF tells us that we're in the third ventricle. And there we are. And once we've gotten there, we introduced an endoscope, had a look around. So basically, we've now opened up the third ventricle, we opened the cyst into the third ventricle, and looking at it, we can then see that we've got a clear third ventricle that we can essentially be happy with. And we then go ahead to visualize it and make sure that it's adequate. It turns out that it's a good 11 millimeters that we've got. So here we are, we're looking at it endoscopically, and we can now see the pineal. We can see, as we shall very soon see, the vein of Galen. We see the vein of Galen, see the basal veins of Rosenthal, we see the internal cerebral veins, and we know that we've got the pineal there, and now we've got the third ventricle, and this is the child on the third postoperative day looking pretty pleased. And what we see is this is the pre-op situation. This is on the 5th post-op day. We see that the cyst has decompressed. We've got a wide opening into the third ventricle. We've got the aqueduct opening up, as is the fourth ventricle, and this is scan day 14. We're beginning to see the cerebellum open up, and things are beginning to look good. So again, using the same small steps for a broader impact, minimal approach, same thing, using neuroanatomy knowledge being vital in tackling lesions such as this. We've again tried to show that it's important to recognize your anatomy if you're going to do something like this through a transbrow supraorbital craniotomy. These are used for approaches for meningiomas, metastatic brain tumors of the anterior skull base, gliomas, craniopharyngiomas, epidermoid cysts. This is the case that was successfully then done. We won't go through the various details, but there are important neurosurgical, neuroanatomical landmarks that one must follow for these approaches. And essentially, you want to go through the eyebrow, avoid injury to the supraorbital nerve, and ensure that you have a good sized craniotomy just across. You then drill the base near the roof of the orbit so that you got better access, and essentially a small bone flap can then allow one to get in and remove the tumor. I won't go into the video of the surgery itself, but this is the post-op of that particular patient, and a happy patient who is quite pleased not having a large craniotomy for what he had been threatened with for his large meningioma. The same thing for a craniopharyngioma, going through this lamina terminalis. This video wasn't running, but this is after we've gone through the lamina terminalis and exposed and evacuated the craniopharyngioma for his lesion. And this is the intraoperative view after decompression, and you can see the optic nerves, the optic chiasm, well demonstrated, opening through the lamina terminalis and entering into the craniopharyngeal. And another happy patient with a incision that's hidden very well behind his eyebrow. So the message is that, as in any surgical endeavor, understanding the surgical anatomy is the key. It's imperative to recognize the underlying pathology, for example, what the problem was in the patient with the hydrocephalus, and select the appropriate surgical procedure that's most suited to address the underlying pathology. Gracias, Franco, for your multitude of small steps that have widened the horizon for so many of us. I thank you for giving me an opportunity, along with Chandrasekhar, to serve as a chair of the Neuroendoscopy Committee. Your foresight in selecting a multitude of excellent committee chairs in every neurosurgical field. You didn't make a lot of noise, but with those small steps, you highlighted that leadership can be sought from all across the globe, not just from HIC countries, but HIC and LMIC countries as well. You give meaning to the term equal opportunity, regardless of region, gender, or creed. And thank you for being a moral conscience of the WFNS. I thank you all very much for giving me an opportunity to pay tribute to a great friend, a great leader, and somebody we will always be proud of. Thank you all.
Thank you. Dr. Matthias, I just want to let you know that Dr. Azmi is back, but he will be waiting to the end of the session, answering questions if there are any, okay? Just to let you know. So, but you can proceed with the next speaker.
Okay, thank you, Imad. Thank you, Mahmoud, for this beautiful presentation. The next speaker is Roman Bosnak. He's head of Department of Neurosurgery from Hubanja, Slovenia. And the topic is Endoport Guide, Endoscopic Transchoroidal Fissure Approach to the Posterior Third Ventricle. Roman is connected.
Roman is muted.
Roman, you are mute now.
I'm just solving the problem with screen sharing. Because I'm doing this now in the car.
Yes, we have seen a lot of scenic.
I saw you driving all the time. I got concerned.
Well, I'm driven, but now the computer asked me to allow and go to system preferences and these things. So I think, sorry for.
We can't hear you, Abe.
Yeah, maybe we can carry on. Yeah.
It's like a drive-in presentation, huh?
Drive-in.
Roman, do you think we should move to the next speaker?
Yeah, I think so. Yeah, because
Okay.
I must get permission and to find this system preference.
Yeah. Okay. So perhaps if you catch up with, then let us know after. Thank
you. Alvaro Cordova is connected.
Yes, for sure. Thank you so much. It's a privilege to be with you, and it is very, very big tribute to Franco Servadei. It's a very honor for me.
Good morning, Alvaro. Happy to have you
Good
here.
morning.
Alvaro Cordova is a
You too.
close friend from Uruguay. He's a neurosurgeon from Montevideo, Uruguay. And his topic for this webinar is brain tumors anatomy with tractography fluorescence and confocal endoscopy.
Yes, I promise to be very brief, Roman. Don't worry about that. I try to share my screen. My screen
Yes.
well? Perfect, perfect. Well, I promise to be brief. Thank you so much. Next, again, for this invitation, a lot of the Neuroanatomical Committee for the World Federation. And I try to show perhaps some things in order to see what happened with new trends in neuroendoscopy, and also learn about another specialties to use different kind of devices, and it's possible also to apply in neurosurgery. But for this time, it's possible to see, to show some things with the use of confocal endoscopy with spectrography, and the use mainly in brain tumors, also in skull-based tumor surgery. So I have no conflict of interest in this procedure. Our experience started a long time ago in endoscopy in 2002 with we met a lot of several very nice, very well-known professors and masters in neurosurgery. I remember very well the start of our activities in Naples, and we don't stop in this kind of procedure since a long time ago up to now. This is our series actually, but a long time ago we have different procedures in neurosurgery, and mainly in brain tumors, more than 120, and also in hypophysis and pineal tumors, and assisted microsurgical procedures in endoscopy and microneurosurgery. So we start with the first time a long time ago with the use of brachytherapy inside of the endoscope, like very interesting possibility to add different devices with the endoscope. And we put inside of the endoscope small wires with the use of iridium, like a brachytherapy in a pineoblastoma in this case. And it's very interesting to see what happened with this kind of procedure. See a lot of necrosis after the procedure, and was possible to aspirate with the use of the endoscope. So it's possible to see with the endoscope what happened with this kind of treatment. And we try to check the anatomy, intraventricular anatomy, and intraventricular tumor. But then this is one of the first of the procedure that we used a long time ago with a very huge residue of oligodendroblastoma, and we see here the CT controls after the procedure. This is the picture that we show putting inside a small wire inside of the endoscope, and it's possible to put a lot of different kind of wires using of the iridium 95 inside of the endoscope. Then the axiom navigation, mainly the use of the axiom system or device, mainly than the optic device in the S7 Medtronic machine. A long time ago we start. But I never forget, because I am also a neuroanatomist since a long time ago when I start studying medicine. And I never forget this, the old authors, the old masters in anatomy, because it is incredible, but all of this anatomical authors and masters, actually they are very actual, despite the use of the very sophisticated software in MRI and a lot of very sophisticated machines. For example, this is a very nice book for Raymond Viozan, Neurographia Universalis. And it's possible to see the fixation by boiling water and boiling oil to fixate the tracks that is possible actually to see in MRI, and it's possible to use in different procedures. Also for Professor Klinger. And it was very nice, the experience for Klinger that he abandoned in the Narrenturm, that was the tour of the fools in Vienna, with the use of the freezing process, but was very suddenly discovered when he abandoned this kind of brains near to the window, and he discovered the morning after this procedure what happened with the separation of all of the fibers. That was not an unexpected result, was an unexpected result of this kind of things, and actually it's possible also to see what happened. So that was in 1835. This is our laboratory. You see in July 14 in 1982, when I was a student in the second year of our anatomy and medicine study, we start to dissect this kind of fibers, and was show this kind of results in the Mar del Plata in Argentina, the Congress, and it was the Rio Platense Congress. This is the name. Activities, both activities with Montevideo and Buenos Aires and Uruguay and Argentina, anatomical departments. So I never forget all anatomy. And it's possible also to compare what happened with this kind of use of procedures with endoscopic confocal approaches, also a minimal invasive access that they are very well known for all the colleagues, from behind, for example, from transfrontal approaches, from below, despite of this lesion near to the clivus, near to the cellular region, upcellular region, near to the cerebellopontine angle, and a lot of different kind of access that is possible that normally possible to approaches. This is the common repairs normally in anatomy. But what happens if you add for these procedures a 0 degrees road endonasal, or perhaps inside of the small approach, minimal invasive, the use of 0 degrees contact endoscopy. That is very easy and very nice to see, because it's possible to use this kind of optics in the micro range of dissection, not only in the macro range, also in the micro range. So it's possible to see. This is the first or the second, perhaps, generation of contact optics in 0 degrees, was developed by Professor D'Andrea from Portugal, was an anti-surgeon, mainly specializes in laryngeal process, and it's possible also to use in urologists in the bladder tumors. So you see, you can use this contact optics for the first generation to see like a common optics, but a contact optics in the surface when you stain all of the surface and cells, and it's possible to recognize a lot of different kinds of cells, tumor and normal cells, run a lot of red vessels inside, red cells, sorry, inside of the vessels, as it's possible to see, and I will show you in a small video. This is the contact confocal optic of Professor D'Andrea from Portugal, that is possible to use with sterile blue methionine, hematoxylin, eosin, and fluorescence, also in the last generation of confocal optics in lasers devices. So you see the use of common 5-fluorescein in the surface of the tumor, as also is possible to use, but a special device in the tip of the optic, and you compare with the range of the resection and the micro resection of the tumor. So it's possible to see the normal anatomy of the tumor, the normal anatomy, or perhaps the pathological is the best term, around of the tumor in the brain. It's possible to colorate with this kind of stainers, and it's possible also to use the fluorescence at the tip. This is one example of a huge grade 1 or 2 glioma, and also to add the tractography softwares, normally in the brain navigators, or also in the MRI machines. So it's possible to put and to develop this technique of multimodality approach of brain navigations during the resections, using the using the electromagnetic devices and the Axiom system inside of the endoscope, this kind of endoscope, and to check in all of the surface around of the tumor, which is tumor and which is edema, or what is normal tissue in the micro range of the resection. This is one of the possibility to see with you need also a pathology specialized besides of the procedure of the resections. It's possible to see in a glioblastoma the very strong stainer cells around of the normal area. And it's in this kind of a multimodality approach, you try to check where you are near to the tumor and near to the edema, near to the normal brain. And also you check in the microresection range with the confocal endoscopy. This is one of the pictures. It's quite similar to the normal slices normally in a microscope, a common microscope. It's possible to see also or to use in different regions. Perhaps this is one example of pontine malignant glioma, that the approach in the with tractography and also with the use of brain navigation. And in this kind of optics, normally the function is very well like like common optic that is possible to check with very clear images near to the suboccipital lateral approach. This is the brain stem. This is the normally the bed of the tumor after resection. So it's possible to use like a common optic and very clear images with 0 degrees. You see a lot of structures in the upper part near to the tentorium, the fourth nerve, the posterior part of the brain stem, and a lot of subarachnoidal and arachnoidal space. We try to aspirate very careful. You see a tentorium. You see the culmen of the cerebellum near to the upper part of. You see also the posterior upper cerebral arteries. So it's possible to use like a common image of the this kind of approaches. You see here the petrosal vein, the fourth nerve for the fourth part, for the posterior part of the brain stem. This is a retrosigmoidal keyhole approach. So it's possible to use like a common optic. You see here, you see the post-op. But here it's possible to see what happened when you stain all of the structures. And here it's very interesting what is possible to check. You see a lot of vessels, normal and abnormal vessels, a lot of cells around, a lot of pericytes. You see the red cells running inside of the tumor, of the vessels of the tumor. And it's very interesting to see stem cells also, cancer stem cells, and a lot of very interesting varieties of cells that I will show you in the next scheme, the next slide. For us, it was very interesting to use. I repeat that this is the first or second generation. Actually, you have a very sophisticated laser procedures, very expensive. They are unimproved. Normally in the first world, actually not in the third world, are the companies. You see here very interesting part of the infiltration of the glioblastoma around a lot of pericytes near to the cells of the tumor and to the vascular cells, the pericytes of the vessels of the tumor. Here is very interesting schema. You see what happened normally in, for example, a glioblastoma. You have an invasive niches, angiogenic niches also, and a lot of different kind of cells, lymphocytes, cancer stem cells. They are the very circular or very normally near to the vessels cells. They are quite difficult to describe, but normally they are under the perhaps the basis of the residue of this kind of tumors. And a lot of pericytes and a lot of hypoxic niches also, endothelial type cells. That's all in these cells is possible to check with the common microscopical sliced, but also with the confocal endoscopy. So the range of the microsurgical resection, of the endoscopical resection also is very useful, this kind of endoscope for trying to testing what happened with the normal resection. This is post-op. Also, it's possible to use through the nose, normally in an Indonesian approach in pituitary tumors, mainly in 2 or 3 millimeters in deep. It's possible to see what happened with the normal gland. It is possible to check which is normal gland and which is tumor. Here you see different, actually, the last generation of confocal endoscopy with infrared Steiners, also with lasers, but they're very expensive and normally it's not perhaps quite similar with the first 2 generations. Here you see the pituitary adenoma. You compare in the upper part. It's possible to see that with the endoscope, and in the lower part of the slide, it's possible to see with a common microscope. So here is the video, and it's possible to see when you introduce in during the resection, after the resection, of the tumor during the endonasal approach to stain the surface and trying to recognize what happened with the stainers and with the cells. So it's perhaps you see here different kind of stainers actually with hematocylin eosins and a lot of different kind of actually very modern stainers when it's possible to check these cells. Our experience started in 2013 and 2017. This is a lot of patients and different varieties of the malignant glioma, low grade, pituitary, skull-based astrocytoma also. And we try to check what happened is really important to improve the extension of the microresection. I think that the advantages of the kind of technique is a multimodality approach with brain navigation and tractography, try to delineate the normal and the pathological anatomy of the tumor, the use of endoscopy normally in the micro-range resolution, try to check the safety of the resection, maximal or minimally, actually thinking about the supramaximal resection that is under the top of the wave actually in neurosurgery, and the use of common reactives without complication at the brain surface because they are sterile and normally we have no infections and problems. The problem is normally like in a lot of procedures in endoscopy and in neurosurgery, we need a learning curve and try to coordinate the use of 3 microrange increases in this kind of optic. Sometimes it's possible to obtain blurred images, poor enhance of cells, and normally a little bit more spend time during a common operation. This is one of the last papers then trying to use a very special, very well-known company in neurosurgery, try to prove what happened with the use of this kind of procedure during the resection. In summary points, I think that confocal microscopy and endoscopy with mainly fluorescein sodium, sometimes it's possible to green indocyanine and a lot of stainers, also with 5-ALA is possible to use. We try to show much more detail of the anatomical structures and distribution of the tumor. It's possible to use in the multimodality approach with brain navigators, mainly for the use of spectrography, and with the axiom and normally with electromagnetical devices inside of the endoscope. And normally the thing is it will possible or not to ensure the much more extension in the resection if you compare with the supramaximal or maximal resection that actually are in the upper part of the wave over the world in neurosurgery. Thank you so much for your attention.
Matthias?
Yes, you muted Matthias. Yeah.
Yes. Thank you very much, Professor Álvaro Córdoba. And I don't know if Roman Bosch-Hack is connected.
Yes, I'm
Hello, Roman. You are still in your car?
No, no. Yes, but I'm doing.
We can't listen to you
Very well.
properly.
So I think
You sound.
Oh, just a moment. You hear me?
We can't hear you.
But
correctly.
You can see me. Oh, okay.
Yes. You
can hear me.
We can't see you, Roman. We can't see
Yeah,
you.
I know that, but can you see the picture?
We
Yeah,
see
can
the
see the
slide.
slides.
Yes.
Ah,
we
all
see the
right.
See the
slides.
slide, and the audio could be better.
Yeah.
Ah, I believe this. Yes, yes, yes.
Now we hear you.
You
Perfect.
hear me now?
Yes.
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 Okay, so I will try to give this lecture in tribute to Franco Servadei and his achievements as a past president of World Federation Society. So my presentation will be on endoport guided transchoroidal feature approach to posterior fourth ventricle. So I have nothing to disclose. The lesions that grow in posterior fourth ventricle and pineal regions, they are very rare. They are less than 1% of all brain tumors, and they are from germ cell line, pineal line, glial line, and miscellaneous. So these tumors are either benign, but radiosensitive or malignant or radioresistant. Are the beginning. So in every case, the biopsy extent of removal is also important. So in benign, you should not produce any deficit at all because they are radiosensitive, and in malignant, again, produce no deficit. So for large posterior fourth ventricle pineal tumors, the open approach is most popular and used today are interhemispheric posterior transcallosal or posterior occipital transcortical. But we can approach these lesions also from anterior posterior side by endoscope. So there are at least 4 approaches. So one denoted like A, it would be a single or dual trajectory full endoscopic approach where we can do some biopsy or a partial removal. Also, we can use the endoscopic shaft and steerable flexible fiber endoscope. But for lesions in the posterior ventricle that protrude also to pineal region, we can use also supracerebellar infratentorial endoscopic approach. So we published last year. So here in this picture, you can see how we entered under the pineal veins into the posterior ventricles and how much this space can be exposed and nicely approached by supracerebellar infratentorial route. But what I would like to present is the endoscopic approach from anterior side, transcortical, transventricular, transchoroidal fissure approach. So in this approach, we are working lateral to fornix or medial to choroid plexus, and we split the pinea from the thalamus into great cerebral veins, and we can approach either in strict midline between the internal cerebral veins or lateral to one. So in our technique, we are using the endoport. So this is a transtubular, completely endoscopic visualization approach. So here is something for anatomy refreshment. So our approach is from the frontal right parasagittal direction close to cochlear point through the cortex into the fourth ventricle and behind the foramen of Monroe. So this is a panoramic picture showing the intervein approach, but of course we can go also lateral. So we can nicely see the posterior fourth ventricle anatomy. So aqueduct here, then posterior commissure, pineal recesses, and the upper surface of the pineal gland. I will present the first case we were doing last year, and this is producing the obstruction of the aqueduct, and there were the size was about 1.6 centimeter, and there were different ideas what kind of tumor this is. Of course, CSF cytology was completely negative, and our aim was to do at least a biopsy through the transthyroidal route. So we were doing the patient with navigation, presenting everything here and approached by plan. So here how we improvise the tube. So first we put a translucent PVC roll around the endoscope, and we use part of this stamp as a cuff. So under navigated endoscope, we insert this into the ventricle, we remove the cuff, and we have to unroll the PVC roll by balloon. So after doing this, we expand this from 6 to 1.5 millimeters, and we can introduce to this port. We improvised about at least three instruments, endoscope and 2 instruments for manipulating by hands. And we are doing, in fact, microsurgery the same way like in open surgery. So here are some slides showing starting splitting the fissure. So here we see plexus, the fornix, the septum, the choroid plexus, and we were starting splitting this here. And we found this lesion, and we took a biopsy from here, and it came out that this was some tissue, but histology was negative, simply because we were not deep enough, but we were in the thalamus. So this was a very good lesson, and we repeated after 10 days the surgery. So here is the view through the endoport. So we identified the foramen of Monroe, septal vein, the caudate vein, and we start splitting. This time we were doing splitting not so in the middle or posterior, but very, very anterior at the level of septum vein. Vein back down. The confluence between caudal vein and great cerebral vein and going medial to it, and we were able to below the level of the veins. We clearly presented the aqueduct, which was free of tumor, and here is still some tumor. We were to aspirate to do the complete removal. So now we are going back. Here are both veins. Here are some cottonoid, which we removed, and the surgery is over. The lesion here was a papillary tumor of pineal region, which is a grade 2 to 3. Underwent radiosurgery, and he is without any problem still now. So this is now complete removal, nice situation. And the lesson of this approach was that we must start splitting here as much as anteriorly at the confluence of the septal vein, caudal vein, and the great internal cerebral vein, but not here in the middle. Because when we enter ventricles, we lost, in fact, on air media, and both caudati come together. So here is the right spot to begin. This is now
Roman, I have to tell you, the audio is not very good, and we are missing a lot of your talks. Do you have a cell phone next by, or because there's a problem with the audio? Do you hear us? No, I think we lost him because this is a We lost him. I think it's very difficult to have a nice presentation spoiled by the audio not hearing and frozen. And I think we give him another chance in the future. So we'll just conclude that presentation.
Asmi has got 2-3 minutes to finish off his lecture as well.
Yeah, I don't know whether he's hearing us or not. Do you see him? I don't see him even.
Asmi is here. He's ready.
Asmi, he wants to have few slides and answer questions if there are questions for him. Yes.
Okay.
Yes.
Okay. Thank you. And sorry for the hiccup just now. I think my computer just decided to reboot and become disconnected. So I just continue with my previous presentation. So as you can see here, we do fenestration, but the point that I want to show is following infection, you can see that the tip of the ventricle are attached to the correct plexus and also to the dense adhesion. If you pull blindly, it will lead to intraventricular hemorrhage. So by using that endoscopic technique, we do adhesiolysis and subsequently we remove the shunt and eventually we convert into a new shunt following endoscopic fenestration because the patient is still drainage dependent because we cannot do ETV in such cases post-infection. So another example, following infection, healing process, you can see membrane. This patient actually came with intermittent headache and then vomiting, admitted to hospital, recovered. So discharged and admitted again. As you can see, actually he depends on one hole of the tip of the ventricle. So this is again, fenestration can be done using a combination of bipolar, seizure, cutting it and make the compartment become, communicating to each other. So you can remove majority of this membrane by doing combination of excision as well. So this is another post-infective compartmentalized hydrocephalus. You can see CT scan, different density. Definitely this is more high proteinaceous. Go in, lavage first this component before you fenestrate. If you fenestrate immediately, this distal component, which seems to be very clear, will be contaminated. So this is all involved in the treatment strategy. So this is a 2-year-old girl presented with obstructive hydrocephalus. He got actually pineoblastoma, managed in one of the center, VP shunt done, followed by serotactic biopsy, post-op complication with intraventricular hemorrhage, shunt become infected, biopsy become inconclusive. So we have to take over the patient, and we went in with the endoscope. As you can see, this is the result of post-infective hydrocephalus and IVH following serotactic biopsy. So you go in, we do lavage. You can see now it's much more clear. We have to release all the adhesion around the foramen Monro before we get to the third ventricle. As we clean the third ventricle, as you can see, there is a tumor actually seedling, a metastasis from the pineoblastoma to the to the floor of the third ventricle. In this particular case, we still attempt endoscopic third ventriculostomy, but you can see here, despite we making a very good stoma, the tumor keep falling back into the stoma. So we keep a patient with EBD because the parents try not to have a shunt after have many complications, but unfortunately, this falling tumor into the stoma that we created has obstruct it, and we have to convert to shunt. But by doing lavage, the shunt survive without any revision. So post-operatively, this is how the patient looks like, and this is control scan 18 months after chemo radiation therapy, just a biopsy. Yeah, and then adhesiolysis, you can see it's much clearer and responding well to adjuvant treatment. So this is probably my second final case. You can see here post-infection also, parietal meningocele, infected shunt. So the point is to show here, you can see following infection. So there will be a proteinaceous material, it's very oily, and the ventricle wall actually very stiff. Following infection, as you can see here, this debris and the proteinaceous make the wall very stiff. Then the foramen Monro was also very oblique. So by doing lavage, you clear it, and then you can see all the sediments start to to remove, to float, and eventually the ventricle become more compliant. So this is also explained that when you have post-infection or IVH, it causes stiffness of the ventricle. This also explains why you have a sleep ventricle syndrome following infection, even though CT scan does not show ventriculomegaly, but the failure of the ventricle to open because it becomes stiff after infection indicate that the mechanism of post-infection. So by doing lavage, we can clear it. You can see pre and post lavage, and subsequently this patient require shunt, but the shunt survival are very much more longer compared to without lavage. So last case, 7-year-old recurrent anaplastic ependymoma, again infected with shunt. So you can see from the CT scan, we put an EVD, but patient had fever. We went in, so you can see a lot of debris, actually slough. Yeah. So after once we can clear the slough, and slowly you can start to see seedling of the tumor on the ependyma. So this does not show on the MRI because the tumor are very small. So this, by doing lavage, you can clear the infection. It also add on to the diagnostic, and you can tell the parents that the tumor has seedling almost everywhere. And you can also discover the oncology team so that it gives a clear idea that the tumor has disseminated, and eventually the prognosis of the patient also poor. So in summary, based on our experience, infective hydrocephalus can be fatal, need early diagnosis and aggressive treatment. We have changed from just EBD to more aggressive endoscopic lavage. The endoscopic transcranial intraventricular lavage is safe and effective in children. It facilitates CSF clearance, prevent further neural damage. It's with a minimal tissue traumatization, preserve the function, improve cosmesis as well as outcome. But most important thing, you have to judge based on clinical and radiological finding, and the success depends very much on good case selection. It doesn't work, lavage doesn't work in every case. You have to have a good plan and also technical skill in handling such procedures. So with that remarks, I end my presentation. Thank you very much.
Well, I just received a message from Roman that he was at the boundary, Germany, Austria, and this is where he lost internet, so he apologized, but he made the point. Well,
Yeah.
thank you.
He was trying for a long time, so I was wondering where he was going.
Very difficult.
Okay, I think that's great. I think we have 10 minutes for the discussion. Matthias, what do you think?
Yes, we have 10 minutes for comments or discussion about the last lectures.
I have to say, Asmi, I think that this was a great talk. I think you have got lots of experience with the infective hydrocephalus, pyogenic hydrocephalus, which is a very difficult problem to treat. And this technique of lavage and peeling off the infected granulomatous material is quite effective. I need a lot of experience for that. Thank you for the talk.
Thank you.
May I ask Azmi a question, please?
Yes, yes.
Azmi, a brilliant talk. You've got a huge array of cases that you've shown, and very nicely. You mentioned that you don't irrigate with any antibiotic, and I certainly have used vancomycin in diluted doses. I don't know whether that's the experience of any of the others, that they use vancomycin in situations like this. That's number one. And what irrigant fluid do you use? Do you just use ringers or anything different?
Okay, the first question, intrathecal or intraventricular antibiotic, we used it before, but we found that some cases that post intraventricular antibiotic injection, when we go in with the endoscope, there are some changes. We do not know whether the proper antibiotic property or the chemical reaction towards the ependyma in a reaction to the antibiotic. Antibiotic kill the organism, but antibiotic does not address the debris. Antibiotic cannot remove the infected material. Systemic antibiotic, I think, works well. because patient come with sepsis. So we stopped from using any antibiotic. I think we discussed this in one of the conference. I think Professor Mauricio also addressed the same idea that the reaction of the antibiotic towards the epidema. Maybe the rest can discuss also. The second question is we use the Hartmann solution, warm to body temperature. So we avoid from using normal saline because in lavage, in average, you need a 6 liter. And we have done 24 bottles of Hartmann solution and took about 4 to 5 hours in one very complicated, pyogenic ventriculitis. There are cases where we have to go in multiple times. So do not remove all the debris, only remove the debris that when you try to pull, it gives, when the ependymal laminae is not so friable, because if you go in, it bleeds, it becomes IVH, then you back to square. So you have to deal with infection, IVH, it prolong the problem and you create more problem actually. The selection of the cases are very important. And we do not use in cases where the ventricle are small. There are cases pyogenic ventriculitis, is very small and very friable. Give antibiotic first, optimize the patient, control sepsis, then only go in. Don't rush.
I think we've created a little bit of a debate or dilemma as to whether to use vancomycin intraventricular. We've got to come to some sort of agreement, as it were. Are there any others?
Andre, you want to talk on?
Yeah, my comment is that I agree with Asmi that with when we initially added vancomycin, like we do, for example, also with shunts, we submerge the shunt into a vancomycin solution, etc. But rinsing and then adding vancomycin makes it very unclear about where and what kind of concentration of vancomycin you really have. So we found also some adverse reaction to it, although we were not sure that it was the vancomycin, but we stopped doing that. But my question to Asmi is, how do you maintain the proper temperature? Because the temperature is essential. And initially, I had all the solutions at the feet end of the patient, and then it came through the lines. And when we start measuring it, in the bottle, it was body temperature. And when we start to infuse it, it was less than 28 degrees, just by running through the line. So it is, we had to cover the line in aluminum foil to keep the temperature. This was, for us, it was a struggle to keep body temperature rinsing solution, because if you don't do that, and as you say, fully right, Asmi, sometimes these are prolonged procedures. But I noticed these kids simply don't wake up well. They stay obtunded for hours, and that initially made us rush them to the CT and see what was going on. They really have difficulties in breathing again, starting waking up again. So this was, for me, that was the biggest trouble, to maintain the proper temperature. And we found a solution in having this blood warmer solution that it warms it up to 42 degrees. And then at the end, when you infuse it, it is 37, 36 degrees. But that was a much more struggle than I ever imagined.
We have same problem, because sometimes in order to maintain the temperature, the nurses warm it too hot, which is not safe for the patient. So you have to fill it. We don't have any solution how to maintain the temperature. But the other things is make sure that the child will not wet. So that is another contributory, especially for, you work in a country like we don't have this expensive disposable water impermeable. We use recycle kind of linen.
No, we don't have that. So don't worry.
So we have to make sure that we put the pocket, we modify. Sometimes we get a plastic bag, we modify it and make a pocket. There is a cheap one produced locally or I think by certain company, but make sure that you cover the area where you want to irrigate and it does not wet the child, because the child will develop hypothermia and then you got
absolutely. And this is, I only wanted to raise this because this is a practical issue that everyone will face when they start doing this. It is not for an ETV because that is 10, 15 minutes time. That's not a problem. But if you start doing complicated procedures like tumor biopsies, removal of colloid cysts, you would deal with bleedings, you start doing lavage, and there is a whole series now of doing neonatal lavage for hemorrhages, also to prevent shunting. This becomes a real issue. So we have to look into all these little details, keeping the bottle with the warm fluid as close to your endoscope entrance as possible to keep that. And fully right, you don't get the kit become wet because they cool off so quickly, you can't imagine.
I think we are on the move to any vital questions need to be asked. This is the chance. And if not, I want to be fair to all of you today who attended today, that Professor Franco Servadei, who was with us yesterday, he conveyed his appreciation to the close collaboration with all of you, without boundaries. And he was planning actually to attend part of the presentation today. Most probably he got stuck, but he appreciated your contribution at this webinar and at your work in the different committees. Myself, and I'm sure I will leave the venue, the final statement for Professor Vladimir. It was a great pleasure to collaborate with all the subcommittees from the World Federation and other associations. Especially, we did a lot of collaborative work with the neuroendoscopy, with the skull base. We did some with the pediatric, we did some with some other society, like the Dr. Salman Sharif in Pakistan, Dr. Nasser Vandour with Egypt, the African group in Marrakesh. And we are proud of this close friendship and collaboration. This is for us, this is the credit we got from having friends like you to contribute together in one family to the education of young neurosurgeons. I will leave the final statement for Vladimir. I'm sure he has something to say on that aspect. Vladimir?
Yes, thank you, Imad. I don't have too much to say. Just this screen is showing the diversity and the quality of the speakers, and of all over the 14 webinars you were successful to get really great people and great lectures. So I think that this is one of the best endeavors WFNS has. And as far as I know, Franco appreciates that very much. And he was very supportive of the committees. And I would say that he was very supportive of our committee, which is just perfect. And I think that now I will talk on behalf of everyone who presented at these webinars, that it was your work and your activity which must have been tremendous to write all the mails and to contact people, to beg them for lectures and everything that you did over the all COVID time. It's really extraordinary, such a work. You got the committee just at the beginning of the pandemic, and you devised all these courses and you did great work, Imad. So I believe that we all are very grateful to you, and we thank you very much for your work.
This is a group and team, thank you. And I think this is one hand you cannot clutch, and you see you have used two hands for this. And we do a group clutching, and we'll take a nice picture. Somebody will take a picture of the screen because I'd like to have it in memory. This is a great people on the screen. Well, I wish you a good night, and I hope you will have a nice evening, and hopefully you attend tomorrow, even if you are not talking tomorrow. but we have an exciting program on brain tumors and intra and extra axial. So have a good night and best regard to your friend.
We will. See you tomorrow.
Thank you very much, everyone. Thank you.
Thank you.
Bye-bye to all.